I just love looking out and seeing so many friendly people I know, and some new patients. We have quite a few new patients. Some are math marvels that are here, but I still recognize them. And thank you all for showing up this morning on a Saturday morning. We have an exciting meeting today on several points. Before we start the meeting, I'd like to make a couple of basic little housekeeping announcements. One is that we're going to a new year. And this year, I have to acknowledge Shelley Mathis and her team that put together our meetings. And her steering committee for meetings has done a super job. That's why we have our speaker today, which we'll talk about in a moment, Dr. Greenspan. Shelley, I want to say to you, thank you. And your team are some of the members here from the this next year we'll be receiving shortly an email asking if you'd like to participate in 2017 in becoming involved with Shelley and the planning committee for meetings. We're also putting together a second group that I'll be working with on membership, because one of the problems we have is that there's so many new patients that come into the Metroplex that aren't aware we're here. And there's roughly 40 new people a month that are diagnosed between the three major hospitals. And I like to reach out to those 40 and make sure they come to our meetings, because that first 90 days is so important. So we'll be having a membership committee. And the third is, finally, we talked about having a mentor program so patients can work with other patients, particularly two categories: newly diagnosed patients and those patients that are looking at a transplant. They're pre-transplant. So we'll have a group of post-transplant patients. We'll have a group of patients that have experience with pulmonary fibrosis, which is probably most of us, to work with the newly diagnosed patients. You'll be getting an email on that. So that's going to be happening shortly. You get the emails. If you don't get one, you can reach me, call me, and I'm sure most of you have my contact information. But if you don't, it's real easy. My email is bill@billvick.com, which is my name. And reach me, please. But we like as many. This is a volunteer organization. Nobody gives us money. We don't seek money. The hospitals have been incredibly generous with us in donating space like this. The treats you have out there, the food, all of that is donated to us. But in return, they love to see us be more involved as a community. And the way to do that is to get more people involved. So the membership committee will help drive that. Shelley's group will help in polling people to these meetings. And then the mentor group is going to help more patients become educated about pulmonary fibrosis. So saying that, in a moment I'll introduce our speaker, but first I'd like to introduce Dr. Howard Wong. And Dr. Wong, along with Dr. Puneet Garcha, Tammy Peterson, who is the Clinical Care Program Manager, and Paula Anns, who has had so many different titles on hard-pressed where to point, but she's responsible really for today's meeting. And Dr. Wong, Dr. Garcha, Tammy, and Paula were the core group that I met with about 4 months ago to bring Bader into the mix of PF Warriors. And they've been incredibly supportive. And I'd like to introduce first Dr. Wong. Dr. Wong is Associate Medical Director of Lung Transplantation, and he's the Director of Lung Transplant Research on the medical staff at Bader. He's board certified in pulmonary disease and critical care medicine. He specializes in lung transplantation and interstitial lung disease. His research includes interest in immune biology of lung transplantations, genetic determinants of lung allocation, allograft injury, rejection, and acceptance. And he, along with his team, is one of the reasons we're here today. So I'd like you to help me welcome him. Just say welcome, Dr. Wong.
Thanks, Bill. Appreciate that. So I just want to keep my comments brief, but first of all, welcome to Baylor. And I'm glad that everybody here is able to take the time on a beautiful Saturday morning to come join us. I hope you get a lot, and I really firmly believe that you will get a lot out of being involved in this group. This is a patient-centric group, and I think this is a fantastic example of kind of patients rallying and kind of offering support to each other. There's a couple of comments I'd like to make. In general, hearing from me as a physician, that initial encounter, okay, is really a poor substitute for hearing from somebody who's actually been through it or has it, is going through it. So I think one of the most powerful things about an organization like this is this ability to support each other and really connect and relate and kind of have a resource and not have kind of this feeling that you're all alone with this diagnosis. And the other thing is just kind of looking more broadly. I think from an interstitial lung disease standpoint, we're really in an era of, this used to be a very difficult and kind of frustrating disease to treat in the sense that there just wasn't very much to offer. And I think we're starting to enter an era where medical therapies, so transplant is no longer the only avenue available. Medical therapies are becoming available, and there are things in the pipeline from a research standpoint that hopefully in 10 years or maybe even less, we're talking about this disease as a manageable condition, much like what pulmonary hypertension was 15, 20 years ago. So that is the hope, and I think that will become a reality in short order. And then a couple other things is I want to recognize Paula, so she's standing in the back there, does all the heavy lifting for us. And so what we try to do at Baylor is really kind of form a more specialized unit of nurse coordinators. So we need specialists in terms of physician expertise, but we can't do all that on our own. And really, we rely heavily on our support staff, and that means the physical therapists, that means our dietitians. So it takes a team to really take care of people with rare diseases and do it well. And so I want to recognize all of her for all her efforts. Erin Brooks, the works of Paula, she's excellent as well. She's not able to be with us today. But I think, as we grow, we're going to continue to kind of expand our team in terms of not only physician expertise, but have really the support staff that can take good care of everybody. And then a couple other comments, brief comments. We have an active research program. We're looking to improve and expand our portfolio of research programs and clinical trials in interstitial lung disease. So one active trial, and you'll see some material available up front, is one in looking for patients with scleroderma. So this is one of these systemic autoimmune diseases that affects multiple organs and manifests in the lung and can cause severe organ dysfunction and lead to sometimes requirement for lung transplantation. So this is a study that's ongoing in our center that's recruiting patients that fall into that category. And we have several others in the pipeline, and we will continue to work with Bill and organizations such as this to get the word out in terms of new medical treatments that are coming down the pipeline. And then I think finally, we have a pulmonary rehab program that's run through the Martha Foster Lung Center. And Mary, who's sitting in the back, stand up, Mary. So she's the point person for that. There's that service available here at Baylor, and we're going to hear very shortly a lot about pulmonary rehab and physical therapy and how it plays a big role in not only maintaining the health of people with interstitial lung disease, but really, if from my standpoint, for people who need a transplant, a lot of times that's actually one of the major barriers to even get them there. So being able to go into the transplant in relatively good shape, even though the ceiling is not very high, makes all the difference in the world in terms of recovery outcomes. So with that, I think we'll wrap up, and we'll have our guest speaker, Greenspan, come on.
One of my many job titles is to fix these last thanks for knowing.
I found out last night that Dr. Wong is also an avid rap music aficionado, so at the end we'll be kicking the beat.
By the way, Paula has parking vouchers
wants to know about that.
Thank you.
You know what, I'm sorry, could we keep the front ones up and maybe take the back ones down a tiny bit?
Well, this introduction is a pleasure for me because I've known Noah now for probably going on 3 years. About 2 years, I was aware of him roughly 3 years ago. 2 years ago, like most of us, I went out to our friend Dr. Google and I was researching the disease. And I came across these videos of this wild man in New York who was talking about pulmonary rehabilitation, and he was articulate and insightful and knowledgeable and motivating, and so I started watching his videos. Well, he has 33 videos and on one disease, both COPD as well as pulmonary fibrosis and other one diseases. And I listened to him and I thought, wow, this guy has it nailed. And he kind of, anytime you have somebody that says what you think they're a lot smarter than they are, right? But this guy is saying what I want. He's saying to me, I'm the point of saying to him. So he's a little background on Dr. Greenspan. Not only is he the founder of the Ultimate Pulmonary Wellness Program and clinic with 20 years of physical rehab experience, and he's a principal investigator now in 2 different studies involving one disease. One is a high-intensity aerobic exercise and pulmonary function in patients with COPD, and the safety and efficacy of cardiopulmonary rehab in patients with pulmonary hypertension. He's also, in his role of the head of administration at his center, he's a certified emergency medical technician. He's an advanced cardiac life support provider. He's a professional scuba diver, international in open waters. In fact, I have to comment, he swims with sharks, which curls my toes. He's a instructor and underwater naturalist, passionate for shark photography. He's a musician. He's an artist, a clothing designer under the moniker of Noah G. Pop. But most of all, I think he's a selfless and giving friend to each person in this room. And it's my pleasure to introduce Dr. Noah Greenspan. Noah?
All right, Dallas, we made it. All right, so we're going to have a conversation today. I'm not going to lecture at you for 2.5 hours, although I can. But I really want to engage you in this and be here in the room with you, and I want you to walk out of here getting what you want from today. Any bingo players in the audience? No bingo players in Dallas? Okay. So at certain times I may ask you to speak, to scream, to yell, to sing. Just go with it, trust me. At the end, we're going to make a little YouTube mannequin video that's going around. But I'm here for you, okay? I got 2 hours, or as long as you guys want, or if you get up and leave and there's no one else in the room, I'll stop. But I really want you to get out of this today something that you could leave and start working on immediately. Before I do start of what I'm going to talk about, because I don't really have a plan here, okay? Don't be worried, I'm not a pilot. But I'll go in whatever direction you want. If you have a question at the time, raise your hand, call it out, I'll answer it. You're not going to throw me off. If you throw me off, it'll be more entertaining for you. Before I do start, are there any specific questions, some things that you guys want to leave here today talking about or knowing about?
Did you have to turn off the screen up there?
Do I have to turn it off?
The screen up there, can you turn that off? It shows on your face, it's disconcerting.
We could possibly turn that off. No, we can't possibly turn it off? All right, hold on, let's try. Listen to my voice. You don't want to look at my face anyway. Sorry about that. But some of these things I'm going to show you some video, but I'll stand over here if that helps. and I'll move around a little bit. Anything in particular about PF that you guys want to know?
I just want to know, as far as exercise goes, I know you probably get to it, but no one's ever told me whether it's okay to push myself or not push myself, or, what's the limit as to the...
Perfect. I've done that a couple of times. So, what else? And we're going to talk not just about rehab, we're not just going to talk about exercise, we're going to talk about the whole kit and caboodle, the whole living well with pulmonary fibrosis. Other questions? Topics you want to cover?
Diet.
Diet, yes.
How to protect against, the season of sneezing and...
The sneezing of sneezing. Yes, yes. What else?
Follow on after rehab.
What to do after rehab?
Yeah, how do you keep yourself motivated?
All right, what else?
Keep yourself motivated.
Keep yourself motivated, okay.
Oxygen levels.
Oxygen levels, awesome.
Multiple prescriptions.
Multiple prescriptions, what else? All right, that's a good start. That's a lot of, yep.
I see a lot of advertising on TV for other dreaded diseases and all the progress that they're making, like Crohn's disease.
Right.
When do you think we'll get there with pulmonary fibrosis?
If I could answer that one, we'd be in a gold auditorium right now. But I'll talk a little bit about that. Okay, I'll talk a little bit about it.
How to find a specialist?
How to find a specialist.
I see a lot of advertisement, doctors want to treat you using stem cell, particularly for COPD.
We'll talk about that, yep. And yeah, what not to do. Basically right now, let me make that one simple and we'll get back to it. But if anyone's offering you stem cell, no one's there for lung disease in any. So I know what you're talking about. There's a certain institute that treats lungs, okay? Scam. And not only, I don't know, I'll leave it at that, but another question. All right, I think we should start. All right, so here's the deal. Let me talk about a few things first. When you are diagnosed with IPF, okay? IPF is no joke. I don't have to tell you that, okay? It is no joke. If you do nothing, you will get worse quickly. You will die. Now, I don't want to start with something shocking, but let's start with this. None of us knows when we're going to die. I don't know when I'm going to die, okay? It could be this week, who knows, okay? So one thing that I hate, I would call it a pet peeve, but pet peeve is kind of like I hate when people cough near me. Sorry, that was just a coincidence, okay? Sorry, I would say pet peeve, but pet peeve is like I hate when people sneeze near me. No. But when I hear doctors, medical professions tell people how long they have to live, I hate that. Because the simple fact is we don't know, okay? But when I hear the story of people telling me about IPF, okay, what I hear is I got a diagnosis and I was told that I have between 2 months and 5 years to live, okay? Now, I'm going to tell you a story, okay? Don't be insulted because it's about a dog. As most people know, I respect most dogs more than I respect most people. But I had a dog named Phoebe who was diagnosed with bladder cancer, okay? And the vet told me that she had 3 months to live. I was devastated by the news, and I basically did everything I could in terms of exercise, green tea, you name it. My dog lived 3 more years, but I'll be damned if every single day for those 3 years I didn't think, was today the day, okay? And when a doctor or a medical professional or anybody, or the internet, okay, tells you, guess what? The timer is now ticking, or the sand in the hourglass is now falling down, they do you a tremendous disservice, okay? Because the simple fact is, some people might have, oh my God, it's like you just got hit by a giant wave, and you have this idea like, well, why should I try? I'm going to be dead in 2 months anyway, or 2 years, or 5 years. I mean, and especially, IPF is something that often hits younger people, okay? You don't have to be 80 to be diagnosed with IPF. And the other sad part about this is that IPF is often diagnosed years after the symptoms began, because you've gone through a workup for COPD and asthma and, you know, all these other things that would be like the horse that we think we hear, and IPF is the zebra. You know, there's a saying that says when you hear hoofbeats, think of horses, not zebras, but almost nobody thinks of IPF first. So if you say to yourself, wow, this doctor told me I have 5 years from the date of diagnosis, and I was having symptoms, I'm diagnosed today, but I had symptoms 4 years ago, that's a problem, okay? So why am I telling you all this? Not to depress you. I'm telling you all this because what I'm trying to say is that IPF is no joke. It's huge. It's like the ocean. It's much much bigger than you, it's much stronger than you, it never gets tired. Which means that if you're going to be successful in fighting this disease, we better get ready to get our team together, to get our army together, to put all of our tools together, our weapons together, and fight like hell, okay? If I am in a shipwreck and I'm on a piece of plasterboard waiting here to see what happens, and I hate to use this analogy because I love sharks and I know that they would not harm, but there's sharks swimming around me. I know that scares most people, but it's a disservice to sharks. But the thing is, if I'm going down fighting. And that's, the fact that you guys are even here today tells me that you're willing to fight. Maybe you don't know all the weapons that are available to you. Maybe you don't know that you need to fight. But again, IPF is no joke. It's a big disease, and if you want to fight this, then you need to fight it on all fronts, okay? And by fighting it on all fronts, I'm talking about taking the right medications, having the right doctor, having the right medical team, exercising vigorously, okay? Eating right. Stress management is a very stressful, anxiety-provoking disease. Anyone who can't breathe, even for 30 seconds, knows that, okay? So, also prevention of infection, okay? All these things, they sound simple, and if I say to you, okay, make sure you wash your hands a lot, everybody knows it, but how many people are doing all these things every single day? So when I look at a patient and they come to me and say, is there anything we could do for you? And I say, well, what medicines are you taking? Are you exercising every day? What are you doing? Are you eating right? Are you at the right weight? Are you doing anything for stress management? And what are you doing about infection prevention? Because all these things, on a daily basis, that's what it takes to move this car, okay? IPF is a fast-moving disease in a lot of different ways. And, as Dr. Wong said, the medicine is there now, okay? Some of the medicines are there. 15 years ago, there was absolutely nothing. So there's drugs out there, but don't expect the drugs to reverse the disease. The drugs are like, okay, the car's rolling downhill and the drugs are helping you to go down that hill slower. But the lifestyle stuff, okay, I'm telling you this because I believe it, the lifestyle things that you can do every single day will make much more of an impact on how you feel, on what you can do, on your shortness of breath, than the medications, okay? So if we have the medications, and the medications can stop or slow down the progression of the fibrosis, then it takes the rest of that stuff, and that's what's going to change how you feel day to day, okay? So the thing is that, what do we talk about when we talk about IPF? The number one symptom is shortness of breath, right? But there's a lot of reasons why people get short of breath. Shortness of breath is a multifactorial symptom. So does pulmonary disease make you short of breath? Absolutely. Can heart disease make you short of breath? Absolutely. But can simply being out of shape make you short of breath? Definitely, okay? There are people who are 45 years old that don't do any exercise, that are 50 pounds overweight, that get short of breath going up the stairs. So what I want to try to just open your eyes to is the fact that people will get this diagnosis of IPF, and then everything that happens is attributed to the IPF. Say, oh, well, I'm much more short of breath, I'm more fatigued, it must be the IPF. Stubbed my toe, it must be the IPF. It's not like that, or it might be like that, but even if it is the IPF, we have to start working on some of these lifestyle issues in terms of what you can do every day. And these are things that you can do right now. So let's start. So I have a concept called ultimate pulmonary wellness. And in my opinion, there are 5 things, and I mentioned them already, but I'm going to mention them again, that really will make the biggest difference day to day. There are people around the world that I talk to that I call cardiopulmonary outliers, and these are people that, despite a serious disease, are excelling in what they do. And Bill Dick is one of them, and Bill calls his philosophy space, okay? And I'm sure you've heard him talk about that before, but all the people that I talk about that, despite these diseases, are excelling anyway, are all doing very, very similar things, okay? It's like when 3 artists come out of totally different parts of the world and their works all look similar. You say, how does that work? But I think that the real keys are 20%, I don't want to say 18%, I would say 18%. One other thing, don't feel the need to write notes on everything. I'm going to record this, it's going to be on our web, you'll be able to watch it as many times as you want, but I really want you to be present in the room and not just think about what I say, feel what I'm saying. Let's get this collective energy like moving so that we're all, I see people shaking their heads. This is, I hope to be a really special experience where we're kind of like, I feel this energy in the space as opposed to like me lecturing at you, okay? So number 1, 18% medical, I call it, okay? Medical is having the right doctors, having the right program that you belong to, taking the right medicines, and taking them properly, okay? So I've had an opportunity to see Baylor's program, looks great, okay? But having the right doctors, taking the right medicines, taking them properly, that's 18%. The next 18% is exercise, and there's a lot of talk about exercise. What can you do? What can't you do? What should you do? There's a lot of experts out there that are telling you stuff that is 25-year-old thinking, okay? Everything I'm going to tell you today is based on not anything I've read, it's based on my own work that I've been doing day in, day out with pulmonary patients for 25 years. Okay, I know what works best because we've tried it. Or, if it's out there, we've tried it. And there's reasons why we came to what we do now. And I'll talk about exercise in great detail. Nutrition is so important, okay, for people with lung disease, but particularly IPF. And contrary to many situations where people being overweight is the problem, at a certain point, once you get to a sort of critical point where breathing becomes a regular physical activity, where you're working so hard to breathe and you're burning so many calories, keeping the weight on is an issue. And I think, it's amazing. I'm writing a book now called Ultimate Pulmonary Wellness, and one of the most challenging chapters was the nutrition chapter, because it's so hard to find somebody that actually knows what people should be doing, particularly as it relates to lung disease. So if you look at cardiovascular disease, a ton of people are going to come out and say, you need to do this, you need to do this, you need to do this. But if you have lung disease, particularly if you have IPF, the food pyramid is not your friend, okay? Those, whole grains, and I'll get into it in more detail, but nutrition is crucial. And if you're not doing anything to think about your nutrition right now, that's the number one thing I would say to you right now, okay? Next, stress management, relaxation. It sounds like, I'm not talking about laying on the beach in Miami, unless you find that relaxing, and do it. But this is a stressful, anxiety, fear-provoking disease, okay? And this fear and anxiety, it doesn't exist in a bottle, okay? It doesn't just happen and, it's a huge physiologic process, okay? You've heard about the fight or flight response, so tons of chemicals going on. I'm going to get into that also, okay? So stress management, relaxation, and then prevention of infection, okay? Because a cold to you is not a cold to me. So a lot of people came in and tried to shake my hand. I tell you, I don't shake hands, okay? I just wrote a chapter on how to prevent infection, okay? So now, my parents were both sick last week. I was like, sorry, but I can't come to the house. You can't come to my house. But it sounds funny, but it's so important. Because if I shook everybody's hand here and one of us had a cold, and everybody after the hand I shook with that cold, you've all got it, okay? So that's really important. So now, those are the topics, okay? After knowing what we're going to talk about, anything else you want to talk about besides that? And then we're going to go hot and heavy. All right, so let's talk about this. So I already mentioned medical care. So having the right doctor, pulmonologist, cardiologist, gastroenterologist, surgical team. Okay, to me, those are the minimum. Why? Okay, when we talk about lung disease, there's a lot of symptoms that occur with lung disease that are the exact symptoms of heart disease. Okay, when we talk about shortness of breath, it could be a lung issue, and it could be a heart issue, and it could be a gastrointestinal issue, because between here and here, we got a lot of systems, and those systems are crunched up really tight. So if something's going on here, well, it's kind of close to my heart, it's kind of close to my lungs, and it's right around my stomach, but we don't know, okay? A lot of people with respiratory disease also have heart disease, and also could potentially have gastrointestinal disease, but I want to make sure that I know what we're talking about, okay? And that involves the right diagnostics in all those three systems. So it's really the lungs, okay? And if you've got a diagnosis of lung disease, we know we're dealing with that, but it doesn't mean that just because you have lung disease, unfortunately, that, it's not like you take one, and that's it, you check you off. You could also have heart disease, and you can also have gastrointestinal. So if somebody starts talking about shortness of breath, chest pressure, chest pain, or discomfort over here, I want to make sure it's not your heart, okay, before anything else goes on. So I think anyone who's diagnosed with a lung disease, it's worth your while to have an appointment with a cardiologist, at least for a basic workup. Let's make sure that there's nothing going on. I think stress testing is very valuable. I think stress echo is very valuable, because as lung disease progresses, we can also see cardiovascular and heart changes that occur as a result of the lung disease. I also didn't mention internal medicine, and of course, if you have a great internist who can sort of jockey your team, that's well also. But your care can be managed by any one of the above. because of coordination of breathing, because of the compression of the thorax and the abdomen, can also wind up with reflux, okay? I asked Dr. Robert Kano, who's like our best ILD guy in New York City, among a few others, what would be the #1 suggestion that he gives to people with interstitial lung disease or pulmonary fibrosis? And he said, check if you have reflux, and if you have reflux, make sure it gets treated, okay? Because lung disease can increase your chances of reflux, right? We have the trachea and the esophagus, so the trachea brings air into the lungs. The esophagus brings food and drink into the GI system. They're very close together, and if you're working hard to breathe at the same time you're eating, your lung disease can impact your gastrointestinal system, and your gastrointestinal system, if stomach acid is coming up, can flip over into the airways and affect your respiratory system, okay? So again, if you have a diagnosis, having the right doctor means the right lung doctor, the right center, the right lung center, and looking for centers of excellence for interstitial lung disease, cardiology workup, and at least to rule out heart disease, and gastroenterology. The other thing is that there's something called silent reflux. Okay, so a lot of people can actually have reflux and not know it. So if you have this heartburn and you wake up and you have a bunch of stuff in your throat every morning because it's dripped down overnight, that's classic reflux. Okay, one of the things about classic reflux, but you can also have silent reflux. And even though it's silent, you don't have any symptoms, that acid can get into the airways and definitely increase the inflammation. So that's medical. Taking the right medications, taking them properly, okay? And that's medical. Any questions or comments about that?
I have a question on that. I have not had an issue with the reflux or the, but when as I've been taking Esbriet, that has been something that has started, and my pulmonologist put me on the something, I call it
pantoprazole?
Yeah.
Okay.
For that, and even though I don't always feel it, it is something, and for that very reason.
Right.
And that was one of the first questions she asked me as I started taking it was, are you having heartburn, are you having those issues? And it's come and go, but I do take that now every day just because that's been a symptom of,
right.
An effect of the estrogen.
Right, absolutely. So pantoprazole is in a class of medications called proton pump inhibitors. So that's like your Nexium, omeprazole, Prilosec, things of that nature, okay? So that's a great thing to do because, again, like I said before, we're fighting a war, right? So we're fighting this war, and we don't want to lose ground on something stupid, right? It's like say, hey, we didn't realize we left our tent open, and a bear crawled in and ate all the supplies, okay? You want to make sure that you're fighting that war, and you don't want stomach acid coming up and, kicking up inflammation in our already inflamed respiratory system. So that's awesome. I'm not saying what you should or shouldn't do. I'm saying these are things, if you're not doing them, talk to your doctor about it, okay? I don't know any of you except Bill. I would never come here and give you advice. This is what you should be doing, but at least raise the questions and say, hey, you know what? I was at this lecture. Do you think that we should look into reflux? Is there anything I should be taking? Do I need to look into my heart? Okay, let me just talk about one other thing as it relates to the heart and the lungs. Okay, a lot of times people with coronary disease. Okay, when I talk about the heart, there's three main things that I worry about. There's three things that I feel like could get you in trouble very quickly. Like IPF is not going to get you in trouble overnight. Okay, it doesn't work like that. Okay, the heart can. And when I worry about my patients, when they come in, I do something called risk stratification, which is where I say, these are things that might get my patient in trouble during their rehab stay. Three things related to the heart. Number one, coronary insufficiency. And coronary insufficiency relates to the circulatory system of the heart. So how does blood flow through the coronary arteries and supply the heart muscle itself? So like when somebody says, angina, squeezing chest pain down the left arm, but that's the classic, coronary symptom, but you could get it in other ways, and I'll talk about that too. So coronary insufficiency, arrhythmia, right? So that's the electrical system. So coronary insufficiency is the circulatory system. Arrhythmia, like a lot of people with lung disease wind up with something called atrial fibrillation or supraventricular tachycardia or things of that nature, okay? And then the third is heart failure, okay? So those are the three things that I want to make sure absolutely before I do anything with you, that's ruled out. And if I ever have any doubt about that, then I am going to send that patient back to their doctor for a workup before I'm willing to push you. And the point I'm making here is that some of the symptoms are similar, and if you have a lung disease, then very often what happens is, oh, you're short of breath walking uphill? it's your lungs, okay? But we also know that IPF can make you at greater risk for right heart pressures, and we know it can make you at greater risk for heart failure, and shortness of breath is one of the symptoms of heart failure. But the other issue is that because of lung disease, a lot of people may not get up to the level of activity that elicits their cardiac symptoms. So what do I mean by that? Most people talk about, when I say to people, why are you short of breath, or what makes you short of breath? So in my practice, everybody's short of breath. Okay, that's all I treat, people who are short of breath. And it could be from COPD, it could be from interstitial lung disease and pulmonary fibrosis, it could be from heart failure, it could be from pulmonary hypertension. Those are my biggest areas of interest. But the mechanism of what makes them short of breath is what makes things different, okay? But the thing that I hear most often from people is walking upstairs, and in New York City it's walking up subway stairs because they're not built for comfort, they're built for efficiency. It's kind of like walking up that stairway to heaven, walking uphill and walking fast or running for the bus, okay? So we call that in New York City triathlon for pulmonary function. I don't know what you do here in Dallas, but walking upstairs, walking uphill, running for the bus. Anything else? Walking fast. What's that?
Getting dressed.
Getting dressed. Showering. Awesome. We're going to talk about those two because that's something that nobody understands, everybody complains about, but when I tell it to you, you're going to be like, why didn't someone tell me this 25 years ago? Okay? But we'll talk about that too. So here's the thing about shortness of breath. When people get short of breath, okay, they start getting short of breath at high levels of activity. So if I know that walking up subway stairs makes me short of breath, then I'm going to take the bus. So imagine if I walk up 4 flights of subway stairs a week, and I work 5 days a week, which I don't. I really work 7 or 8 days a week. But that's 4 flights of stairs, 5 days a week. That's 20 flights of stairs that I'm no longer walking up and down because I'm now taking the bus, right? So that doesn't just affect my lungs. That affects my heart muscle. That affects all these muscles. It also affects lung function, okay? There's a lot of people who are going to say, you can't affect lung function with exercise. I don't believe that. I think you can. I think you can improve it in a lot of situations. I think for the people that say you can't, I think they're not exercising people vigorously enough, okay? And we'll talk about that. But people start to get short of breath, high levels of activity, they eliminate those activities, and now they start to get short of breath at lower levels of activity, okay? Then they start to eliminate those. So maybe now I know that if I have to go up 59th Street, then I'm going to walk up a hill, so I'm not going up 59th anymore. I'm going to take a flatter surface. Now all the muscles I used to walk uphill get weaker. My heart gets weaker. My lungs become less efficient. Then I get short of breath when I walk fast, so I'm not going to walk fast, right? So how many people, when you have this experience, a lot of times people will say, I'm walking with my friend, and I have to come up with an excuse to stop so I can catch my breath. I don't want to tell them I can't breathe. Or I'll be walking the street, and I'll stop and look in the store windows, right? Because I don't want people to know I'm short of breath. But the point is, what I'm trying to say about this is that you can get significantly more short of breath. And let me tell you one thing. If you look at the classic literature on pulmonary rehab, they will say that patients get better, they feel better, they can do more, they're less short of breath, but there is no change in lung function. Now again, I told you I don't believe that already, okay? But let's take that as if it's the truth, okay? What does that tell you? You're less short of breath, you can do more, you feel better, you're less anxious, but there's no change in lung function. What does that tell you? That tells you that there have to be other factors besides just the lungs that either make us more short of breath or less short of breath. So my point is to tell you that, not to say, okay, like I said before, if we do nothing, this car is coming downhill. It's going to roll right over us. But if it doesn't matter if my lungs get better or get worse, and I can somehow get less short of breath or more short of breath, I'm going to choose less shortness of breath. And I'm going to choose to do the things that I do have control over. Maybe we have control over the lungs. We have less control over the lungs. Okay? We have more control over going to the gym and not eating that Arby's Big Boy and not letting stress take over our lives, okay? And washing our hands. Those are things we can control. So I'm not here to say, hey, you know what, and I don't want to turn this into a meeting about, give me the serenity to change it. But that's really the truth, okay? Other than take your medications, there's not a whole lot that we can do to change the progression of the disease and transplant and those types of things. But the everyday stuff, I'm telling you, that's the 80% of it. That's the stuff where you're going to feel totally different. And not only that, you are no longer a victim. You're not waiting for the disease to come up and take a bite out of you while you're floating on the water. You're saying, you know what, I may go down. We're all going down to something. We don't know what, right? We're all going down. But like I said, if I'm going down, I'm going to go down punching and kicking and fighting and screaming. And the way that you do that is what you do every single day. Okay? I'm not going to sit here and say to my lungs, stop making scar tissue. Please stop making scar tissue. Please. But I could say, hey, you know what? I'm going to the gym. I'm going to kick some ass in the gym, or I'm going to eat this, and this is going to make me feel good instead of making me feel like crap for 4 hours. And I'm going to do some meditation because I need to turn off these voices in my head, and I need to turn down all this adrenaline that's shooting through my system every day, because all those things make a difference. And all those things can change the progression of your disease, or at least the things that can impact how you feel, because these things are all chemical and they're all inflammatory. More and more, I'm starting to think that inflammation is a key to life or death, okay? Meaning that stuff can, how does stuff get in? It'll get in through our eyes, it'll get in through our nose, it'll get in through our mouth, it'll get in through our gut, okay? And if you want to think that you only have inflammation in your lungs, no. If you got inflammation in your lungs, you got inflammation in other places. If you got inflammation in other places, you got inflammation in your lungs. And so the point is, I want you to start doing things to quiet that system down. That's medical, 18%. Let's go to exercise, okay? What do you want to know about exercise? I'm going to tell you everything anyway, but specifically, what are some questions or concerns?
How hard can you go?
How hard can you go?
How frequently?
How frequently?
Best exercises.
Best exercise. Anything else?
Intensity.
That's how hard you can go, yep.
The best way to use oxygen with your
Best way to use oxygen. Okay, awesome. So this is what we just talked about. So there's a formula. It's called FIT, right? You guys just did it for me. So it's like frequency, intensity, time of exercise, type of exercise. Those are the 4 things you could change about exercise, okay? Frequency, how often? You guys are going to answer. So how often should you exercise?
Every day.
All right, my work is halfway done. Every day. It doesn't mean you have to go to pulmonary rehab every day. It doesn't mean you have to go to the gym every day, okay? But let me tell you, this is like money in the bank. Everything we're talking about now is money in the bank. So if you do nothing, and it's not like you do nothing, your bank account doesn't change, okay? You do nothing, you know your bank account goes down. So every day that you do nothing, and when I say do nothing, I'm talking about you don't exercise, you don't eat right, you don't do any meditation, you don't take your medications right, you don't wash your hands 50 times, okay? Every day we do nothing, stay sedentary, and make no action, we're losing money, right? Every day we're doing something, it's like putting money in the bank. And you're going to say, well, some days I wake up, I can't think of doing anything, right? So you know what? Put a penny in the bank. We're still moving forward. We're still moving. And on the days that you feel great, it's like surfing. You go out, there's no surf, no waves, go home. The waves are there, you ride them. You have a good day today, you feel great. Usually you walk a mile a day, but today you feel great. Walk a mile and a quarter, okay? Don't set the limits in your head before the limits present themselves by your body. And that's what happens too often is we say, oh, I have IPF, I couldn't possibly do that. And then you go to certain doctors, and the doctor says, you know what, you have IPF, you get your, take it easy, okay? And you go to the therapist, and some of the therapists, you know, they're saying, well, let's take it easy, let's teach you how to slow things down. I'm going to tell you something right now. If you learn anything from this one thing, here's the message. Everything I just said, slow it down, take it easy, is the opposite of what you need to be doing. You need to pick things up, you need to not take it easy, you need to get it in gear, you need to fight. And that's what's going to get you going. And maybe today's not your best day, okay? So, but I'm going to put something in, okay? It's like I'm going to put something in today, every single day. And I'm going to put a chart on my refrigerator that says medicine, exercise, nutrition, stress management, prevention of infection. I'm putting at least one check in the box of every one of those boxes. I promise you, those things don't add up, they multiply. And it's scary to start, okay? When you go and nobody's giving you any information, you're like, I have this disease, I don't know what it is. Let me tell you something about interstitial lung diseases, okay? And interstitial lung diseases are so complex, okay? So for the doctors that understand, Dr. Wong's a humble guy, okay? He's just a regular hip-hop doctor, okay? But interstitial lung diseases are so difficult to understand because nothing makes sense about it, okay? The names don't make sense. The treatments, are hard to understand. Even pulmonologists often, who are long experienced pulmonologists, have a difficult time with the interstitial lung diseases. So we can't possibly expect that you are going to understand it completely, but you have to understand it at least a little bit, okay? So exercise, let's talk about it. So frequency, we said every day. As I said, you don't have to go to pulmonary rehab every day. First of all, we know your insurance isn't going to cover that, okay? But you should be doing something every day. Could you go to pulmonary rehab twice a week, 3 times a week? Yeah, because pulmonary rehab is a time where you're going to be pushed to your maximum hopefully under monitored conditions, okay? And that's the time to push yourself, okay? But on the other days, walking, okay, strength training, bicycle, anything that you have, okay, it's like Nike says, just do it. I'm gonna say, just do something, almost anything, and it's gonna be beneficial to you. Maybe it's not putting $100 in the bank, it's putting $5, $10, $20 in the bank, okay? There's something else called armor size, which I will make this program available to you, but it's things like uppercuts, stir the suit, upper body stuff, and we'll talk when we talk about, you know, showering and dressing, why the upper body is so important as well, and why you get so short of breath when you're taking these different, when you're doing these different upper body activities in particular. But you should be doing something every single day, okay? Again, every day that you're doing something, we're holding that car up the hill. Every day that we're doing nothing, we're bringing it down. Frequency every day. Intensity. This is the, yes ma'am?
Time of day.
Whatever's good for you, okay? There's no particular time of day that's going to make it more beneficial. I'll throw one seed out to you. The thing I like about exercising first thing in the day, okay, there's a lot of things I like about exercising first thing in the day, okay? Here's one thing. Let's talk about it from a heart rate, blood pressure, anxiety perspective, right? If I start my day here, right, and this day is getting all over me and it's stressful and it's anxious and all that, and my blood pressure and heart rate get up here, and then I exercise and it brings it back down to here, right? You with me? Now here's something else to think about. Let's say I start here, and before I even get a chance to go to work, and the boss is a jerk, not at my place, but although Caroline's going to be like, no, he's a jerk. But you start here, right? And then you do your exercise and you come down here with your blood pressure and your vessels open up and your heart cools up. And then whatever your day gets, it only brings you back to here. So you see like your max is not getting as high there, okay? Because we know that stress and you know, the blood vessels and all this stuff plays a role in hurting us. So that's one thing about exercising first thing in the morning. And the other thing is that no matter what else happens in the course of your day, you know that something happens every day, you've done it already. You've done it already. So that when you come in and you're cool, and you know the effect of exercise when you're actually doing it, the acute effect is that it's going to increase your heart rate, increase your blood pressure, maybe decrease your oxygen saturation. But after the exercise is done, guess what? The blood vessels are nice and wide. The heart is pumping nice and efficiently. Okay, you're breathing nice because your airways are relaxed, right? You also have smooth muscle inside your airways. And that smooth muscle is very susceptible to the course of the day. So like you see football players exercising, and if it's a cold day, they have to take extra time to stretch out, right? But you have smooth muscle inside your airways. And if you go without that muscle, you know, tightens up and constricts and gives you less room for air to flow out, as opposed to if you exercise and you do it all in a controlled way that makes sense scientifically, your airways open up. So a lot of times people will try to get out of rehab by saying, you know what, I'm really having a lot of shortness of breath today. And we don't want you to come if you're sick. We don't want you to come if you're, you know, if you're having an exacerbation, if something's really wrong with you. But if it's just, we know that there are going to be things that get in the way of our day. If it's a smoky day, if it's a humid day, if it's a cold day, that's going to make it more difficult to breathe. And if nothing's wrong, like if you're not actually sick, I'll say come to rehab, because I know that after the exercise, your heart will be more efficient. It'll be pumping more blood with each stroke. Your airways will be relaxed. Your blood vessels will be open. And a lot of times people walk out and say, boy, I feel so much better now. And that also, all these things plant little seeds in your mind. And those seeds grow. And you're like, oh, I'm more sugar rush. What's going on? Am I getting worse? Is my disease getting worse? Am I, you know? And those are the things, some of it's real, but a lot of it is not real. And so I say to people again and again, I say this to people in everything that they do. Don't let your brain, don't let your thoughts limit you before your body gives you the real indication that something's wrong. So time of day, if you can do it in the morning, that's great. There's another aspect to this, which is that the relationship between exercise and eating, okay? Because a lot of people probably feel that after a meal, okay, it's harder to breathe. And so that's not the time. Now there's a whole bunch of physiological issues that go on with that. So we talked about, I'm going to talk a little bit about the autonomic nervous system. So I'm not going to make this super scientific. I'm going to just break it down easy. So there's two nervous systems that we talk about, the autonomic and the voluntary. So the voluntary is, I want to raise my hand, I do it. I want to put my hands out to the side, I do it. But I don't have to stand here and say to myself, to my heart, I don't have to say, beat, right? I'd be exhausted just from beating my heart. And when I go to sleep every night, my heart would stop beating. Same thing with breathing, right? Now, breathing is interesting because breathing has combinations that are voluntary and that are autonomic. So can I say breathe hard and fast? Yeah, I can do that. But at a certain point, I can hold my breath. But at a certain point, my body's going to say, no, you're taking a breath, whether you like it or not, okay? So there's autonomic and voluntary control. So we want to control the voluntary part of it, but we can also do some things to control the autonomic parts of it. So there's autonomic system is then further divided into sympathetic, parasympathetic, right? You hear these things all the time. You're like, oh, I always get it mixed up, sympathetic, parasympathetic. So it's like sympathetic, think of it like this, it's your friend. It's there to help you. Another way to think of sympathetic nervous system, fight or flight. So I'm walking, all of a sudden, 6 Texans, no, I'm just kidding. But I'm walking, and, all of a sudden somebody jumps on me, or a bear jumps out, or a pterodactyl, a caveman, but it sounds funny, but that's how this all came about, right? So you're walking out, picking berries, caveman is walking and picking berries for family, and a pterodactyl comes and tries to sweep them up. So we have two options now, fight or flight. So you've heard about the fight or flight response, right? So this pterodactyl, I don't want to become pterodactyl food, so I can either fight this pterodactyl or I can run away. And your body has a lot of adaptations that it does to do that. So think about what would be beneficial to you. So would it be beneficial for all the blood to rush to your stomach because you just ate? No, we want the blood in our arms, we want the blood in our legs so that we can fight. We want our heart pumping hard, we want to breathe, we want our airways to open up, we want our eyes to open, and we want our pupils to allow us to see when that pterodactyl is coming. That's fight or flight. So that originally came from a very prehistoric, primitive protection mechanism, except that in today's times, today's times really more than any other times I've ever seen. I'm not going to make any political statements because I am in Denver and I'm from New York. But if someone's writing a check on the checkout line before us, we're like, oh my God, this lady's writing a check. Every time I come to this lady's in front of me, she's writing a check. I'm in a rush. That is having a very similar, maybe not to the same degree as if a pterodactyl is trying to sweep me up, but my heart starts beating faster. My blood vessels constrict, my airways can tighten up. Well, airways shouldn't tighten up, but this is the effect of adrenaline, because I am getting ready to fight or flee, but I'm not going to fight the 85-year-old lady writing a check in front of me on the checkout line, but I'm getting mad, and without an outlet for that outlet being exercise, fighting, or fleeing, it constricts your blood vessels. It makes your breathing more difficult. That's the sympathetic nervous system. And rest and digest is the opposite. So that means, it's coming up to Thanksgiving, right? We all have this experience where the night's over, we've stuffed ourselves in the leg. Oh God, I could fall asleep right here. And granted, everybody blames tryptophan, partly blame it on the turkey, but a lot of it has to do with the fact that there's so much food in here, and we get a huge amount of blood flowing to this area, away from our brain, so if I said to you right now, all right, get up, we're going to get on the treadmill, that's the last thing you want to be doing at that time, right? But the other aspect about eating and respiration is that there's a mechanical issue, right? So if you know a little anatomy, we know that the lungs are here, the diaphragm is a dome-shaped muscle that sits here, right? And it contracts downward, and when it contracts downward, that's what inflates the lungs, right? And below that is all of our gastrointestinal content, so our intestines and our stomach and all that stuff. So the more you have here, the more that's pushing up against the diaphragm, and the harder the diaphragm has to work to contract downward and to open up the lungs. And the other thing is that if it really pushes up, then guess what? That's compressing our lungs even more. And we know that with pulmonary fibrosis, we're already going to have compressed lungs as well. So think about it like this. If I have a glass of water and I have a Dixie cup, and I want to fill up a bucket over on the other side of the room versus having like a 64-ounce beer mug, then with that Dixie cup, think about how many more trips I have to make in order to fill up that thing right here, as opposed to a 64-ounce mug. So it's the same thing with breathing, right? So the less air you move in and out with each breath, the more you have to breathe, right? The more frequently you have to breathe. It's a very simple formula. There's something called minute volume, which is the number of breaths you take per minute times the amount you move in and out with each breath, right? You multiply that, that's how much is moving. Now you can do that in a lot of different ways. So if I'm taking a breath, that's 500 milliliters per breath. In order to get up to 6 liters, I only have to take 12 breaths per minute. But a lot of people here, most people here, are not taking in 500 milliliters per breath, right? Some people may be only taking in 150 milliliters per breath, or 200. So at 150 milliliters per breath, instead of those 12 breaths per minute that I'm taking, so that's 1 breath every 5 seconds, I instead have to take 40 breaths per minute. So that's 1 breath every second and a half, and that looks like this. And I'm sure a lot of people here know what that feels like. There's a lot of problems with that, okay? First and foremost is that the trachea, the airway, the windpipe, okay, holds about as many milliliters of air as you are pounds. So if you're 150 pounds, okay, some people are saying like 150 pounds, let me get that 150 pounds. Some people are saying, I wish I was 150. But if there's 150 milliliters, if you're 150 pounds, that means you have to get at least 150 milliliters of air to pass the windpipe, because nothing in the windpipe gets into your bloodstream. That's the whole idea behind controlled breathing techniques, and that's why we teach you these controlled breathing, to try to get as much air out and also to take as much air in, okay? You know, I come to meetings sometimes that it's like the Jets and the Sharks, the COPD patients versus the IPF patients. Like, this doesn't apply to me, I have COPD, this doesn't, it applies to everybody, it's yin and yang. So what goes in, what goes out, if you have a problem with inspiration, you have a difficulty with exhalation as well. So don't think of it as that, but the key is you have to surpass it. So if you're breathing 40 breaths per minute and only moving 150 milliliters of air per breath, and you're going, none of that's getting into your lungs. So the eating and then exercising, or the eating and breathing, that's the connection between eating and breathing, okay? So we talked about anything else related to frequency of exercise. That's where we're talking about now, and then I'm going to get to intensity. Frequency. Intensity of exercise, the cosmic question, how hard should I work out? I have a YouTube video on it, but I'm going to tell it to you better than it is on a YouTube video right now. You have to work out pretty vigorously, okay? You have to work out almost as hard as you can. Now, let's talk about what are the keys. So the keys to working out vigorously, it's got to be safe, okay? So we don't want you overdoing it, but at the same time, we don't want you underdoing it. This is like Goldilocks of exercise. We don't want it too hot, we don't want it too cold, but it's of course worse to overdo it than to underdo it. But if you think about the potential benefit of exercise, like underdoing it, let's say if you only get 50% of the benefit because you're afraid to push yourself, and you multiply that by 100, think about how much of a disservice you're doing to yourself. And part of the problem is that the healthcare professionals are saying to you, when you get short of breath, you should, you need to calm down. You need to take it easy. You need to stop. But by learning controlled breathing techniques, okay, and understanding the science behind what's okay and what's not okay is crucial. So how do we know if we're okay or not? Okay, I'll tell you what I look at. First of all, I like to do an exercise test on every patient, okay, because I want to know what they can do and what they can't do. But let me tell you some of the problems with exercise testing when it comes to pulmonary patients, okay? If you look at the classic protocol, the most common protocol that people use is called the Bruce protocol. And the Bruce protocol, how many people here have had a stress test before? Okay, treadmill test, right? So the most commonly used protocol, and I'm saying like 90% of people who get stress tested get this protocol called the Bruce, that starts at 1.7 miles per hour, 10% incline, right? That is very, very vigorous for a lot of people to start. If you get through the first 3 minutes, it goes to 2.5 miles per hour with a 12% incline, even more vigorous. And if you get through 6 minutes, the next 3 minutes are going to be 3.4 miles per hour with a 14% incline, okay? So the problem is, what stops the test? So if you think about your last exercise test, why did they stop you? What's that?
Perfect.
Sometimes, okay, sometimes heart rate, sometimes blood pressure, but more often than not, the tests are stopped because the patient is short of breath or their legs are too tired because they're not used to activity. So a lot of times I'll get a stress test report and it'll say like, patient did 1.5 minutes of the Bruce protocol, negative for ischemia, which means that we're ruling out heart disease based on that 1.5 minutes. However, they only did 1.5 minutes. Okay, so they didn't really reach a heart rate. They didn't reach their peak heart rate or their maximum age predicted heart rate. They didn't reach their peak blood pressure and their oxygen saturation. Very often they don't even measure oxygen saturation during we have no choice. We have to stop the test. Whereas maybe if we would have tested you on oxygen, and I'll talk a little bit more about how much oxygen you should get and how should you get that oxygen, but that test is almost useless to me because we've ruled out heart disease, but I didn't see any cardiovascular or hemodynamic endpoint that tells me we should stop the test. Now, there's a peak heart rate. There's an age-predicted maximum heart rate, which, you know, in most circles is 220 minus your age. So if you're 80 years old, we would say your maximum heart rate, age-predicted, should be 140. That's the normal healthy population. But if you have heart disease, if you have lung disease, a lot of medications that people take will alter their heart rates, make them either faster or slower. So I don't want to know an age-predicted. I want to know the actual for you. So there's the predicted, there's the actual, and there's the actual. So when I say the predicted is, I know your age, I can do math, I can subtract your age from 220, that's your theoretical maximum heart rate, but your actual maximum heart rate is what I will see on the stress test. So if you did the stress test, and you may be 70 years old, so your theoretical max heart rate would be 150, but on the test you only reached 130. Then I can only say what happens up until 130. Anything after that, I don't know. It's like we know this plane flies up to 25,000, you know, safely. We don't know what happens after that. Same thing with the heart rate. And then when I say the actual, I mean, yeah, we may have just done this test and gotten 130 on you, but if the reason for stopping the test was shortness of breath and lower extremity fatigue, then this is less useful, and we have to look at other factors as well. So that's one thing. The reason why I'm talking about exercise testing is because the exercise test, based on those results, will set the intensity of exercise that you're going to work out when you go to rehab. So, for example, they may say, yes?
Should all of us have had a stress test?
I believe you should. I believe if you have IPF, then you should have a stress test. Why? Because there are, you know, it could increase the workload on your heart, it could increase your chances of arrhythmia, and there's no harm in doing it. It's one day, you get your test, you find out if you have something or if you're not, and then if we rule it in, it needs to be treated and addressed because maybe that was contributing to your shortness of breath in addition to pulmonary fibrosis. And if it's ruled out, then when you're walking up the hill and you feel this squeezing in your chest, you can say, I know it's not my heart because I've already had it checked out, right? I don't like to guess. I don't want to be like, what's your name? I don't like, Barbara, come here. Let me see you do some push-ups. Let me roll the dice and see if these push-ups knock Barbara out. You know what I mean? I want to know for sure. I don't like surprises and stuff. Yes, sir?
How often should you have stress test?
Depends on your doctor, okay? But I think if you're diagnosed with a lung disease or anyone who's really having symptoms of shortness of breath, chest pain or pressure, reduction in exercise tolerance all of a sudden. So you used to be symptomatic walking up 4 flights of stairs, now it happens on 2 flights. Or you used to walk, get short of breath only walking uphill, now it happens on 5. That's a baseline. You know what I mean? Let's at least get the baseline. Let's deal day to day. Let's deal day to day, month to month, year to year, and let's make it based on science. Let's make it based on your symptoms. So if there's a change, okay, then by all means, let's look at it. But a stress test is the beginning. A lot of times we can have false negatives, we can have false positives with just a straight stress test. In most stress tests, we're walking on the treadmill and there's a 12-lead EKG. Ideally, there's also going to be what's called a stress echo. So as soon as the test ends, they do an ultrasound of your heart because we know that pulmonary fibrosis can also increase the pressures in the pulmonary artery. We know that that can also go back and increase the pressures and the workload on the right side of the heart, right? The right ventricle, the tricuspid valve, the right atrium. And the right side of the heart, is the side of the heart that's usually the low pressure side of the heart. But because of lung diseases very often, that can also be high pressure side of the heart, except the problem is that the machinery on that side is not built for those pressures. So again, I think it's worthwhile to get the stress test, get the echo, let's see the baseline, let's see how things progress as time goes on. There's no harm in information. The more information we have, the better. And I'm not advising willy-nilly go get a test every week. But let's get a baseline. Based on that, let your doctor implement some treatments. Let's see how those work out. But guess what? Maybe if you're also having increased heart issues as well, and then those are treated, maybe now you're much less short of breath, and you had a combination of lung and heart issue or something like that, and now we'll exercise. But I would say at least a year, not every year necessarily, but again, if your symptoms change, if things change, then you got to look at it. I don't want to assume, it's probably this. You hear a lot of it's probably this. Maybe it is, maybe it's not. I want to make sure I know what it is.
How about nuclear stress test?
I think they're great, particularly for people who can't, who can't do the treadmill, right? So the nuclear stress test is basically where the chemicals are going to do the work for you, okay? So that is, is not going, pharmacological tests are not going to make you walk on the treadmill. So for the person who's too short of breath or has orthopedic limitations or things like that, the nuclear stress test will get to the bottom of it. But it's not, you don't want to give people unnecessary radiation. They don't need it. But you always start small. It's like if I see a bee, I'm going to try to, I'm not going to hit them with a hammer first. I'm not going to hurt the bee anyway while I'm talking about it. But you want to start with the basics and work your way up.
How do you determine whether you need the physical stress?
Ask your doctor. Your doctor should know it. Okay, it's like your internist should recommend you to. But here's the thing: a lot of doctors may not think about it. Okay, they should. A lot of doctors will. And Dr. Wong, don't jump me after this. I'm not bad mouthing doctors, but a lot of times things get missed where someone doesn't think of something. So the question I would ask is, do you think I need a stress test? Okay, what kind of stress? Because a lot of people don't even know what a stress test is. Okay, they have this idea, or a lot of people say, did you ever walk on a treadmill? They say, well, yeah, when I had my stress test, and they had to pick me up and throw me on a gurney and start, that's the worst experience, right? But understand that the stress test is designed to cause stress, right? Like for me, I'll just sit in a chair and I'll have people come and nag me all day, and that'll be, tell you if my heart is in good shape or not. But the thing is, people don't know that there's different kinds of stress tests. So the most basic is a regular stress test, EKG only. Okay, it's going to tell us about the electrical activity in the heart, but you can have false positives, false negatives. So if you're going to go that far anyway and get a stress test, get the stress echo, because then we also learn about the mechanical function of the heart as well. And those two things, the electric and the mechanical, remember I talked about the 3 risk stratification before. That's going to tell us about arrhythmia. It's going to also tell us about circulation. It's also going to tell us about pumping power of the heart. So that's one thing, okay? So back to, we're talking about intensity, and this all leads up to intensity. Yep.
Sorry, one more. Is there an age at which you wouldn't start with the physical stress test?
No. You mean, can you be too young or too old?
Too old.
No. No. Absolutely not. I mean, everybody, but again, it's about choosing the right test. I mean, listen, I spend most of my day around people who are between 80 and 100 years old. Okay, and I'll show you some videos. You're gonna, when I show you the videos, you're gonna be like, what? You're gonna check your eyes because you're gonna see people working out who are 85, 90 years old, working out vigorously, and they're not different than you. Okay, they're not different than you. You guys are my people with a funny accent. Okay, so they're not different. The reason I'm going to show you these videos is because people look at this stuff and they say, no, that's not me. That's too much. And I'm going to show you it's possible. Okay, these are not young people in old people masks. But the point is that you want to check it out, make sure it's going to be safe. Now, here's why I say that the predicted, the actual, and the actual. If you, and this is a mistake that a lot of people make, which is that if I get you up to a test, and the reason why we stop the test is shortness of breath and lower extremity fatigue, but your heart rate's good, your rhythm's good, your blood pressure's good, and your oxygen is good, then for me to cut that workload and say, like a lot of people say, well, you're going to work out now at 60% of that workload, right? Or 80% of the workload, thinking that that's your maximum heart rate or your max workload, but it's really not, because it wasn't the hemodynamics that stopped the test. The test was stopped by your breathing and this. So I would say to any program that's exercising people, they should do the right test, make sure you do a test that's not so vigorous. We have a test we use called the Benson protocol, which starts, instead of at 1.7 miles per hour with a 10% incline, it starts at 1 mile per hour, 0% incline, which is about this. And if you can walk in here, then you can take that test. And if you make it through the first 2 minutes, then it's at 1.6 miles per hour, 0% incline. And if you can make it through 4 minutes, then it's 1.6 miles per hour, 2.5% incline. And now I've seen you exercise for 6 minutes at 3 different intensities, including a little incline, which everybody says, oh, I can't do incline, or don't do incline. You have a bad back, don't do incline. You have a bad hip, don't do incline. But incline is your best friend, okay? I see people walking very quickly on the treadmill. If they're not using incline, they're doing a very big disservice. And I'll explain to you. I have some slides. I'm not going to get tracked down with the slides, but I'll show you what I mean in science later. But the point is, if that's what you've done and the limiting factor was shortness of breath and lower extremity fatigue, then you should go to that intensity 100%. Work up to it. Within the first 3 sessions, I want to see you at the same intensity that I tested you at, and then after that we're going forward. Now, we talk about oxygen use during exercise. Okay, how many people use oxygen? How many people use it only during exercise? Okay, so here's the thing about oxygen. There's a myth about oxygen, which is that people, and it has more to do with COPD patients than IPF patients, but there's a myth that some people think that you're going to somehow poison yourself with oxygen, or that you're going to somehow get oxygen toxicity, or that you're going to take too much oxygen and you're going to stop breathing somehow. Okay, it's all bull. Okay, or I could say, I can make a political statement now. Wrong. Okay, so the point is, use as much oxygen as it takes to keep you saturated. Okay, the way that the oxygen hemoglobin dissociation curve, forget everything I just said, but think about it like this. It's a S-shaped curve. Okay, so what that means is that between 100% and 90%, things are about the same, but when you drop below 90, 89, 88, it's like a cliff, right? So this is the stage. So here I am at 100%, right? And imagine it's like Mount Rushmore or something, Grand Canyon. I come to, here, now I'm getting to 90, 88. That first step is a doozy, okay? So for people who say, you know what, you can go to 89 or 88, no, you can't. Because the problem is, and there are people who are going to argue with you, okay? Listen, you're going to go to some people and they're going to say, you know what, this guy doesn't know what he's talking about, or this and that, okay? But the thing is that for me, I want to give you every single tool that you need to achieve the maximum benefit and not get hurt. So, in other words, when you start going downhill, your heart's working harder, right? Your heart has to work harder. The pulmonary artery starts to squeeze, right? So pulmonary hypertension, secondary pulmonary hypertension is often a secondary, side effect of having a lung disease for a long time. So the thing is that if you go down and I have you on, just shout out how much oxygen you're using. How many liters?
5,
2, 4, 5, 3. I'm going to tell you. How many? 4. 2, 3, 4, 5. I'm going to tell you something right here. If that's what you guys are using to exercise, some of you are definitely way under oxygenated. Okay? Because I'll tell you the numbers I use. 8, 10, 15, 25, right? Nobody's got a concentrator that goes to 25 at home. That's why we rehab, right? Because you can't possibly do at home what we could do with you in the clinic. And likewise, we don't want you doing that, right? When I have you in my place, what I'm doing, I have your EKG on the board. I'm monitoring your heart rate and rhythm the entire time that you're there. I'm checking your oxygen every 5 minutes. I'm checking your blood pressure every 5 minutes, not just at the beginning and the end, right? Because checking it at the beginning and the end is like, well, how does this plane fly? I don't know. We'll take a measurement before we take off, and then we'll take another measurement after we land. Meanwhile, the plane could be like, and that's what the workout could be for you too, right? If we check your vital signs only at the beginning, heart rate, rhythm, blood pressure, we don't know what's happening during the actual workout, right? So it's really important to ask people to check your vital signs during the workout at the peak, because you may be 120 over 80 with rest, and maybe when you exercise you're 220 over 140, and that's not okay. So with the oxygen, okay, you need to, everyone, I think it's really important, everyone should have their own pulse oximeter. Okay, the pulse oximeter is going to tell you heart rate, and it's going to tell you oxygen saturation. It's not going to tell you the rhythm, okay? You need an EKG for that. But this is going to tell you, am I getting enough oxygen? And understand that there's a greater difference going from 91% to 88% than there is going from 91 to 100%. And it's the same thing with treadmill. It's like, it's not like each 1% has the same value. It's like, we look at coins, I could give you a quarter, I could give you a dime, this guy could have a quarter and a dime, this guy could have a penny and a nickel. They both have 2 coins, but they have very different values. Same type of thing with the oxygen saturation. So the people that are going to say you could go to 89, you could go to 88, you could go to 87, they're not taking into account the damage that can be done to the heart, to the pulmonary arteries, increases your chances of arrhythmia, increases your chance of coronary insufficiency, increases your chance of heart failure on a long-term basis. So use as much oxygen as you need. Now, that brings us to another question. But I only have this concentrator, and this concentrator only goes to, right? So think about this. First of all, when you have a concentrator, they're going to give you numbers that may go from 1 to 5 or 1 to 6. Okay, understand that those are not liters per minute of oxygen. Those are settings. Those are your company's settings. And you have to look at it and say, well, how do I know if I'm okay? Or how do I know how much I need the oximeter, right? So when a pilot flies, okay, you may know about this, but when a pilot flies, they don't rely on what they see because their eyes can play tricks on them. When a scuba diver is underwater, they can't rely on how they feel because, as far as how deep are they, because the body plays tricks on you. And it's the same type of thing with oxygen saturation. So you have to rely on your instruments. The same way that a pilot or a scuba diver relies on their instruments, rely on this, okay? So your doctor may say, hey, you know what? You should be using it on setting 2, but that's based on what we're seeing in the office, right? There's a big difference between sitting here when you're getting checked out versus walking up that hill. So I say turn it up as high as you need to maintain a saturation. I like 93% plus. Okay, now again, that brings us to another dilemma. My tank only lasts for this long. My concentrator only provides this much oxygen. So in those situations, you have to work within your limits. But when you go to rehab, so there's a difference between the portable concentrator that you have and the concentrator that you plug into the wall and the tank of oxygen, right? So the least efficient, the one that's going to give you the least percentage of actual oxygen is going to be that portable concentrator. The next best one is going to be the concentrator that you plug into the wall. And the single best, okay, like the purest cut crap, no, I'm just joking. But the best one is those tanks of oxygen, okay, because that's 100% medical grade oxygen. So if you're on your concentrator, even if it's plugging at 3 liters, right, and I put you on a tank at 3 liters, then by all means, you're going to be much higher saturation on that tank with 3 liters than on your concentrator. So what can we do about that? Continuous versus pulse. Okay, that's another issue. So with the pulse, what that means, everybody who uses pulse knows it means that it's only going to give you a breath when you breathe in. Similar to a scuba tank, right? If I take a scuba tank and I breathe like this, I'm going to drain that tank very quickly. Same thing with your pulse oxygen. Same thing with your pulse oxygen concentrator. And the other thing about the pulse oxygen concentrator, remember what I told you before about this 150 milliliter trachea here, right? If I just go, a lot of people do this, they go, got my oxygen, got my oxygen, got my oxygen. But you are not getting oxygen by doing that. The way that you're getting oxygen is by going. So make sure when you trigger that, right, that you are taking a deep breath with each one so that gets into the lungs where you can use it, okay? It takes a lot of concentration. And the things that I'm talking about today, whether it's exercise or nutrition or stress, these things take effort, okay? They take you fighting. They take a concentrated effort. But you know what? If I put you in the middle of a war zone, you better believe you didn't spend the effort to make sure you have the right weapons and to stay down or to run. This is a war zone, okay? IPF, you're fighting a war, okay? And this is your army right here. So you have to take this seriously because you know what? No one's coming into your house and doing something here. It's here, okay? So let's fight it, Bill.
Can we take a 10-minute break?
Yes.
The restrooms are right in front of right in front of the elevator, go all the way. Let's be back here in 10 minutes. It's now 11:30. So
11:30. Oh.
11:01.
All right. 6 more hours, whether you guys. And if you have specific questions, please come back and we'll get through it all. I met my best friend in the lobby. Coffee. It's fun. I always am hesitant to use the bathroom while I'm mic'd up because I'm afraid. All right, so I'm going to show you guys a little video just so that you get an idea of what I'm talking about, so you know it's not just. Are most people back? All right, so let me just show you a little video. I have a few videos. You're lucky because I skipped through the 20 least interesting slides. This one's interesting. We need to
Make a lot of way. Crank it. Let's bother the neighbors.
90.
How you doing, Alan?
I feel terrible.
I would have said, if you tell them 30 seconds before, I would have said, fine.
That's what they all say. Take your hands out of your pocket. Act like you're interested. Once our patients have been here for a certain amount of time, we require them to dye their hair the color of the center. How's the speed, Henry?
This gentleman has an idea.
Can you attach them back?
25 liters of oxygen.
Let's go to the bottom. Let's see what that looks like. Let's see if Henry
I'll talk to you about how much oxygen you can do. He's in his late 60s. But this guy, this is a very athletic person. He's always been an athlete.
Eat your heart out, Bill, Vic. Just kidding, Bill.
But these two got Bill and this gentleman have a lot in common. That's Henry Brown.
What do you do after this, Henry?
Go to Disney World.
So you get an idea of what I'm talking about. I'm not advising you to get up and start running on the treadmill. Those people that you see there doing that didn't start that way, okay? We did the same testing that I'm advising that we do with you to establish their exercise prescription, okay? But little by little, we build them up. Now, I talked earlier about the idea of some of the concentrators don't do what you need them to do. Or, there's a saying when it comes to like construction work, they say everybody wants three things. They want a job that's done well, they want a job that's done fast, and they want a job that's done cheap. And they say that you could have any two of the three. So you could have it done cheap and good, but it's not going to be fast. You have it done cheap and fast, but it's not going to be good. Same type of thing with oxygen concentrators, right? So everybody wants three things from an oxygen concentrator. They want an oxygen concentrator that's going to last a long time. They want an oxygen concentrator that's going to give them a lot of oxygen, and they want an oxygen concentrator that's going to be light, right? You can have any two of the three, okay? Because there's no way that you're going to have a little 2-pound oxygen concentrator that's going to give you a lot of oxygen and last for a long time, okay? That's a fact. And again, a lot of people are limited by the concentrators. I hate, in a way, I almost feel like it's a hoax that people are being given devices that inherently are not going to support their needs, okay? So that's why I say, what we try to do is I try to work with different distributors that will let me hold some concentrators and let us try them out with patients so that you can actually use your instruments and check the numbers to know if it really is good enough or not. But here's some ways that you can get more out of your oxygen or get more out of your oxygen. So let's say we know you desaturate with exercise. So the first thing is, if you have the ability to turn up the oxygen, turn it up. So now, again, I don't know, we don't make our patients use their own oxygen when they come to us. It's so limiting because it's like by the time you get to us and you use it there, you can't get home. And I don't want you guys staying in the house overnight. But the thing is that we give you oxygen. We give you 100% medical grade oxygen. Now, there's another thing. There's low flow devices, there's low concentration devices, and high concentration devices. So most people are using nasal cannulas, right? So the nasal cannula really is only designed to go up to about 6 liters per minute, okay? So imagine 6 liters per minute is that the glass is full, right? And anything else we give you, I can give you 100 liters of oxygen per minute. If it's going through a nasal cannula, all that extra oxygen, it's like wine. It's all winding up on the table, okay? And, if it were wine, we would bend it down and suck it off the table, okay? But you can't do that with the oxygen. It's already gone, okay? So that's one thing to think about. So 6 liters per minute, continuous medical grade oxygen on a cannula is not doing the job for you, then we have to think about what's the next step. The next step is a mask, okay? The masks are awesome. something, because everyone's like, I don't want to wear a mask, okay? But the beauty of the mask is that when you're doing this, okay, we're keeping all that oxygen in, and instead of going up to a maximum of about 40% oxygen, we're able to get you up to pretty much 100% oxygen if we could go up to 15 liters per minute. Oxygen in the air is about 20.96% of the total air. But again, with the cannula and a tank, we're able to get up to about 40%. But again, it really, once you're going above that and your oxygen needs are not being met, then we have to either go to a different device or much more liter flow, which a lot of people don't have the ability to go to 15 liters, 20 liters, 25 liters fill.
Question, your feelings about liquid oxygen, part one, part two, if you're Medicare, how do you get it?
It's a big problem, okay? I think that liquid oxygen is great. I think it's got pluses and minuses, the bills. I mean, to me, the ideal, okay, the best possible way to get oxygen is a tank, okay? A tank of pure oxygen. Now, that comes with its own problem, okay? It's that you have to keep changing your regulator. You have to carry around this big tank. But let's be frank, okay? At a certain point, not at a certain point, I don't want to say it as a definite, but if you know, the interstitial lung diseases are, you know, you can see people with COPD and they never, as a general rule, will need the amount of oxygen that people with the interstitial diseases do. So if you have IPF, we don't see people go from like 95 to 85. We often will see people go from 90 to 60 or 70, you know, something like that. So something like that, you know, the liquid oxygen is going to be limited in how many liters per minute you get. I think it's great if you could get it. I think Medicare is not, you know, I think the insurance companies are not covering it in a way that they do, which is making it harder for distributors to get it, because if they're not getting paid, they're not going to want to go through the extra effort. The other thing is that, you know, the DME companies, the medical equipment supply companies are being choked by Medicare now, okay? And, you know, they can't do it. So if you could find someone who will do it and you'll get it covered, that's great. But I think also, if possible, you know, I'm not going to lie, we live in New York City, we have a lot of people with money. You live in Dallas, you have people. If you have the money, not everybody does, and that's really unfortunate, but I think it's worth your while to say, well, you know what, this should be covered by my insurance, but do you want to make a point, or do you want to live your best life? And I know that not everybody has the ability to say, I'm going to make a decision to purchase this on my own, but if you can, you know, you want to get the best care for yourself. The other thing is that a lot of the oxygen companies will give you this concentrator, you know, the plug-in concentrator. They may give you a portable oxygen concentrator, but maybe the plug-in concentrator only goes up to 5 liters per minute, right? And that's really 5 liters per minute, but it's not the purest 5 liters per minute as if you had a tank. I'm going to let you know a secret. So how much the oxygen company charges your insurance company is very different than what they pay. And what if me, okay, so something that might be charged $75 to Medicare, I could probably get for $10. So I would say this, I would say if you need the oxygen, so maybe you have a concentrator and Medicare will cover that. And maybe you have a portable and Medicare will cover that. But maybe to really exercise vigorously, you need 15 liters per minute, and you're not going to get that out of the portable or the plug-in concentrator. You need the tank. Say to your oxygen company, let me ask you a question. If I pay for this myself, not the Medicare rate, they're going to say, oh, it's $75. Listen, let's cut it. You know, cut the bull. You probably get it for $10. I'll pay $20. And then you got that tank sitting there that you can use when you get on the treadmill or when you go out for your walk or you do this, okay? You don't have to use it all the time, okay? Maybe when you're sitting and doing nothing, the concentrator does something. Maybe when you're going out and driving in your car, your portable oxygen concentrator is going to do the trick. But for vigorous exercise, people with IPF need a lot of oxygen, okay? So say to your guys, this is what I want. I want 12 tanks every 3 months. I will pay for them. Okay, and I'm telling you, if you knew the prices that you could get them for, and what they're paying for them, and what they're billing, you know, your insurance company, it's messed up. Okay, so talk to them and people say, look, this is what I really need. What would it take for me to do this? Okay, and again, I know there's people who don't have the money to do that. Okay, I feel for you. Okay, if you can do it, I think there's people who really can't do it, and I think there's people who have this idea like, nah, screw that. I'm supposed to be covered by my insurance company, right? And you can take that position. You can say, I'm only going to take what my insurance company will give. But but I think ultimately you're harming yourself. So I think if you can sort of supplement in these ways, but use it smartly. Use it at the times when your oxygen demand is going to be the highest, because these are all about supply and demand, right? So sitting and doing nothing, you don't need much oxygen, right? The more you do. So this takes more oxygen than sitting and doing nothing. This takes more oxygen than what I was just doing. Walking vigorously on a treadmill takes a lot. So all I'm saying is that there's ways to sort of work with the companies. And, you know, if I'm paying $10 for something and I could get 20, I'd rather do that than not do anything at all. And I think there are companies that will work with you if you contact the right people and if you make a personal connection with somebody. So that's one thing. The other thing is, so if 6 liters per minute on a pure tank of gas is not doing it for you, you can turn it up, okay, but turning it up has a problem because now you're going to go through it more quickly, okay? Or you can go to the mask, okay? There's a couple of different kinds of masks out there. We use something called a non-rebreather mask, which is the one that's on your face, and then there's a bag hanging down. And, you know, the bag, you know, we're reminded of sort of like those, you know, old, you know, nukes type things, put this on. But what that bag does is it's actually creating a reservoir of oxygen so that every single breath is giving you the maximum concentration of oxygen. So it's like by getting the maximum concentration of oxygen, you can take less breaths. That's also sending a signal. Remember I was talking before about the autonomic nervous system and sympathetic and parasympathetic. When your oxygen starts to creep down, your body's like, wait a second, what's going on here? I have a situation. We better increase heart rate, increase blood pressure, increase respiration. But by giving you that oxygen, we're saying to your body, it's okay. You know, because like if I'm sitting here and doing nothing, and all of a sudden I hop up and jump on the treadmill, my body doesn't have eyes, except these eyes. But internally, my heart doesn't have eyes, my lungs don't have eyes, my autonomic nervous system doesn't have eyes. So your body doesn't know the difference between running on a treadmill and getting chased by a bear. So unless you give it some signal that everything's okay, it's going to assume you're being chased by the bear, and it's going to throw out all the stops. And from a physiologic point of view, if you get off too quick to start, you're breathing hard and fast, your heart's pumping hard and things like that, then you're actually doing other things. Your body is starting to spill lactic acid into it. You know, your bloodstream is becoming more acid, and that also is sending a signal back to the brain saying, breathe, 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 breathe. And then we get into the mechanical issue of we don't have that, you know, breath. It's like if I said all of a sudden, you know, it's the difference between like filing out orderly, or if I say, quick, everybody get out, and we all, you know, bottleneck at the door. It's the same type of thing with your airways, which is why, you know, it takes a lot to really think about, you know, breathing properly when you're using these concentrators. Again, if you're going, all you're doing is going through your tank as fast as possible, okay? But if you take that and go, the lungs are getting, you know, the oxygen's getting into the lungs where we need it, your saturation's going up, okay? It takes a lot to think about, okay? It takes an effort to think about it, and it's not the kind of thing where, like, the more you do it, you eventually do it naturally. You don't. You're never going to do it naturally. Nobody breathes like that naturally, okay? But these are things that I say, you know, I give you a choice. Do you have to do it? No. But if you're telling me I'm short of breath, I have no energy, my legs hurt every time I walk, that is worth it to you, okay? And the beginning is the hardest part, okay? The first 3 months are going to be the hardest part. You can make that commitment for a month, 2 months, 3 months, but really, you know, usually after 4 weeks of doing these changes pretty regularly, you start to see some changes. When you start to see these changes, you say, wow, you know, I used to have to stop 2 times walking up that hill. I just got up the hill without stopping. That's motivating, okay? And, you know, you have so many things that over and over again are kind of playing on your head and beating you on your head and saying, you can't breathe, and you can't exercise, and now you can't, you know, do your own laundry, and now you can't go dancing, and now you can't do this. And it's like a barrage of things telling you that you can't. But in the same way that you spiral downhill by not engaging in behaviors that are positive for you, trust me, you can spiral back uphill. Especially, remember what I talked about before when I said that you can do more, you're less short of breath, all these different things. Or think about the worst, because more people are experienced with getting worse. So you can be more short of breath, you can be able to do less activity, you can have less energy with no change in your lung function. So that's telling us that it's not the lungs, it's all these different things that we're doing and not doing that are doing it. So in the same way that you spiral downhill, guess what? Start to undo some of these changes, and you can start to spiral uphill, but it's not fast, it's not easy. Okay, it's not going to be fast, and it's not going to be easy, but we have one life to live, right? So whether that's going to be for 2 more months, or 2 more decades, or, you know, whatever it is, let's live it to the maximum. Let's utilize it. Let's focus on it. You know, let's expend the effort. something, okay? It may do something for you. It may help to slow the progression of the scar tissue being laid down. It's not going to make you less short of breath. It's not going to make you able to walk up the hill. It's not going to be able to make you bend down and pick up your grandchild. The things that I'm telling you about will, okay? Yes?
Since a lot of people here are immunosuppressed and it'll be easy for them to catch a cold or virus,
Yep.
number one, how to avoid it, and number two, any kind of exercising during a period of illness.
Okay, good question. I'm going to do the last part first because I have another part on specifically preventing infection, okay? So here's the thing. Exercise. You say, well, I'm not feeling well, should I be exercising? I think when we get sick, this is kind of what it's like. So we kind of get a little sick, a little more sick, then we get hit over the head, and we're like, oh, this is terrible. Then we start to get a little bit better, and a little bit better, and a little bit better, and a little bit better. If the most simple way of thinking about it is like this, is when you're rolling down the hill, don't exercise. Okay, when you're going downhill, 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 that's the time when every bit of strength in your body needs to be fighting that infection. Okay, so that time, could you do breathing exercises? Yes. Could you use your acapella? Yes. Could you use your aerobica? Yes. Those things, yes. But that's not the time to get up on the treadmill. And I think by exercising during the time period that you're going downhill can actually make you sicker and slow your recovery. But when you turn that corner and you say, hey, you know what? I feel a little bit better today. That's the time where I think that exercise can actually speed up your recovery and make you, everybody's a little bit different, but in my experience, I think if you're rolling downhill, no. You eat your chicken soup or whatever it is you do, you take your medicine, you rest. But when you turn that hill, that's the time to say, all right, like that getting sick, you're in the penalty box, okay? You're now starting to turn, let's get out there, get back on the ice, So that's other things. So let's just, any questions about the oxygen? Because I'm trying to hit it for you. But again, people can say, how much oxygen should I use? Use as much as you have, okay? And use as much as it takes to keep you at 93% or more. Now again, if your own devices don't allow you to remain at 93%, then you have to be in a rehab program. You have to be someplace where you can get more oxygen, where you can be monitored, because oxygen saturation doesn't exist in a vacuum. It affects other things too. So as I said before, if you're low in oxygen, it's going to increase the workload on your heart. It's going to increase your heart rate, your blood pressure. It could increase your chances of arrhythmia. It could increase the pressure in the pulmonary artery, okay? So you have to be in a supervised environment where we know you're okay, where you can be monitored, okay? But again, it gets tricky because you say, well, what if insurance doesn't cover it, okay? It's a mess. We're in a bind, okay? As a nation, we're in a bind, okay? Because you say, well, what I try to get people to understand, little by little, I'm trying to reach out to local politicians to have my voice heard, but the idea is this. Rehab, at a worst case scenario, let's say it costs $100 a visit, which that's higher for some, lower than others, okay? And you went twice a week, that's $200 a week. If you went 50 weeks a year, you took off for Christmas and Thanksgiving and New Year's, that's $10,000 for the year, right? $10,000 for you to go to rehab twice a week for the whole year. If you go to the emergency room, okay, that $10,000 is gone in the first hour probably, okay? Or if you wind up in the ICU, how much does that cost? So what I'm trying to get people to understand is that, they say it's a cliche that says, an ounce of prevention is worth a pound of cure. It is so true when it comes to pulmonary disease, and that's why prevention of infection is such a big part. Everything I'm telling you, the medicine, the nutrition, the exercise, the stress, they're all equal. They're huge each. And, there are going to be other things that people say, like supplement, there's all little things, but I think overwhelmingly the 5 basics are these things that we're talking about now. So I covered frequency every day, intensity, push yourself as hard as you can, as long as your vital signs are stable. And again, initially, I think everybody should do pulmonary rehab. The beauty of pulmonary rehab are many, okay? But here's the biggest benefit. When I'm walking in the street and all of a sudden I get short of breath and I'm like, oh my God, I can't breathe, okay? And then I'm like, oh, I feel this pressure in my chest. And I say, oh, like Sanford's son, Elizabeth, is this the big one? I am terrified of that, okay? If I don't know how to swim, I'm not going in the deep end of the pool, okay? It's that simple. So if you don't know if going to the grocery store is going to allow you to get there and back without you becoming so short of breath that you don't know if you're going to keel over, okay? No nobody's going to do that. But again, there's physical things going on, there's emotional things going on, and there's physiological things going on, and these physical and emotional, they cycle back and forth. So it's like, I'm starting to get short of breath, fight or flight, sympathetic nervous system. My body's saying, oh, am I going to be okay? This sympathetic nervous system puts out the adrenaline. The adrenaline says, breathe, 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 breathe. But because there's a restriction to our inhalation and exhalation, we can't breathe as much as we need to be breathing. So guess what? We get even more short of breath, then we get more nervous. And that's when you feel like, that's not what we want, okay? But the thing is that the combination of the mental and the physical can either work for you and be your best friend, or they can work against you and be your best enemy. I want you to work towards making them your best friend. And the way that we do it is I see some of these people, it happens all the time. People are walking on the treadmill, and they go, oh my God, my heart is beating out of my chest. And I say, how fast do you think your heart is going right now? And they say, probably about 140, 150. And I say, would it surprise you to know that your heart rate is only 95? And my heart rate is 95. Well, why am people, okay. Would it surprise you to know that your blood pressure is 170/80? That's okay. Would it surprise you to know your oxygen? So yeah, it feels terrible. You are working hard to breathe, okay? But if your vital signs are good, that's the way you get stronger. And that's the way you become more fit. And that's the way your body gets better at using oxygen. And that's how you change lung function, okay? You're not going to find anyone else in the country. You have to go to Tel Aviv, Israel, to find somebody else who's going to tell you that you can improve your lung function with exercise. You know why? Because they're tough over there, okay? And because they're doing vigorous workouts like we're doing vigorous workouts, okay? Most places I know about, okay, if you read the classical pulmonary literature, they're working people out for long periods of time at low intensities, right? You're going to walking at 1.5 miles per hour for 30 minutes, 40 minutes. But think about it like this, very simple formula. If this is what your life requires, and I exercise you at this level, you can do that till the cows come home. You never get better at this, right? But if I do whatever it takes, if I give you 25 liters of oxygen on a mask, 100%, and I can get you exercising here, well, that's something different, and now your life gets better, okay? So I'm not saying this to say, hey, your program is not doing what they, it's not their fault. People don't know about these things, okay? But it's up to you to say to your, you know what, this feels pretty easy for me. Do you think maybe I can increase, and maybe could I increase the oxygen a little bit so I can do a little bigger workout? Ask the questions. I'm not here to criticize anybody or to badmouth anybody, but I'm here to educate you so that you at least know what questions to ask. And if they have questions about it, you can say, well, would you consider watching this webinar? And again, if I were just here and I'm showing you video, okay, it's true. If I were just here talking, if I were just here talking and not showing any proof, but it's true. I'm going to show you another one now because it's a good break.
Say hi to your family and friends.
So again, this is armor size. I'm going to put this on the website. I'm going to make this available to Bill so that you guys have these exercises. So what this is a series of 16 different exercises. Okay? Punching bag, arm jog, marching soldier. And these work. Lay at your own risk.
Mom, do you like this? Mom, you want to get into the next?
So the thing is that, ask the questions and let them, the webinars are all up. So ask the people, would you be willing to, watch this webinar or call me? I'll talk to anybody about this, okay? Because it just is a matter of changing the mindset of the program from slow down to stop and take a break to you're okay, keep going because we have things to do, okay? If you think about it, if I only exercise you my goal is to squeeze every single drop out of every single workout, okay? If I get you for only 24 sessions, you better believe from session 1 to session 24, and the only way that can happen, I can't just say, okay, everybody go exercise. I have to see, okay, Bill, this is what's going on. So your heart rate's this, your heart rate's that, your oxygen saturation is this, but we can go up a little more. And if that's still pretty good for you, then we can go up a little more. I'm going to squeeze as much out of each session, because think about it, if I get only 60% out of each session, right? Remember I said Goldilocks, not too hot, but also not too cold. Think about over the course of 24 sessions, how much waste there is there, okay? People want to fight Medicare, they want to say we're not getting enough visits, and it's true, we're not getting enough visits, but in the same way that I say to you, evaluate your exercise, evaluate your nutrition, evaluate your stress management, I say to programs, let's evaluate your testing methods, let's evaluate your evaluation methods, and let's evaluate your exercise prescription and monitoring, because maybe you're not doing everything that you can be doing for your patients, okay? Nobody's 100%. Nobody's doing everything, not even Bill Vick, he's at like 99.7%. But you know, nobody's at the same. And so I say, look, yeah, we're going to ask the government for something, but maybe they're going to give it to us, maybe we're not. But I say, if the government doesn't give me any food, I'm still going to feed my family. You know what I mean? And same thing here. So if the government doesn't give me any more visits, I have to work smarter, and I have to work harder, and I have to get more and do more with less. And I would bet that most programs are not doing, you know, the 100%. Yes, ma'am?
It's the same thing with these programs, cash costs. You can get into a program a lot of times. I got into mine for $200 for 10 visits.
That's a great deal. That's an unbelievable deal.
My insurance. So.
Yeah, and not everybody can do that. Okay, but the other thing is that there are things that you can, you know, I want to prepare you for you if you can get the Cadillac, and I want to prepare you in case you can, you know, you have a bicycle. Okay, if you can't get into a program, there's no doubt about it. There are going to be people who don't have the right insurance, who aren't going to get into programs, that aren't going to get the oxygen they need, that aren't going to get the medications they need. But that doesn't mean we quit. Okay. And again, I'm not even going to use an animal, you know, I would say a shark thing again, but I hate to malign the sharks. But it's like, if the shark bites off one of my arms, I'm still going to swim with one arm and two legs, okay? Same thing. We have to deal with what we have, and we have to deal with, I'm in New York City. There's people all over the place that are providing care. Here, you have 3 medical centers, and like, if you fall down, you might fall into a hospital. You know? But the thing is that even if you have nothing, okay, there's people who have nothing, nowhere, no access to a rehab program. Some people I talk to online don't even have a pulmonologist, if you could believe it, okay, let alone an ILD specialist, let alone a transplant center, okay? But I still say to these people, let's start walking. So I can only walk a half block. Or fine, you can walk a half block. Then if you can walk a half block, then tomorrow let's walk 3/4 of a block. Okay? Don't set the limit, and don't say, because I can't walk 10 blocks, I'm not going to walk 2 blocks. Okay? I forget who it is. It's a football coach, and I can't think of who said it right now, but the saying is, don't let the things that you can't do interfere with the things that you can do. I think it was Vince Lombardi, that's right. Okay. So the idea is that don't let the fact that you can't walk 10 blocks stop you from walking 2 blocks. Because remember what I said, every little bit that you put in is something. So if you have absolutely nothing available to you, then what I would say to you is walking program and armor size. Okay? And how do you know if it's okay? Let me show you something else. Many people have probably seen this before, right? This is the RPE scale, rate of perceived exertion. So this means how hard are you working? When you're on the treadmill, I have my vital signs. I see your heart rate, I see your rhythm, I check your blood pressure, I check your oxygen, but guess what? There are people who all those things are great, but they're really in trouble. And they're a couple seconds away, you know. So the way that I say this, I say, how hard are you working? Okay, so the idea, and the way that this came about, and it's interesting, if you look at the top is 6 and this is 20, there are some programs that will use 1 to 10. Here's why I use this one, 6 and 20. Remember I told you that peak heart rate is 220 minus your age, right? So if you're 20 years old, then your peak heart rate is 200. Add a 0 to this, right? It's 190, 180. So this, if you think about it as pulse rate, it's a pulse rate of 60 going up to a pulse rate of 200. So that's from least exertion to most exertion, right? But I don't want you to be like, was it very, very light or very light or, you know. I'm going to tell you what I ask my patients. This is where most people are. Is it fairly light, somewhat hard, or hard? Okay? And that's what you can ask yourself as you're walking. So you say, well, I'm starting to feel a little different. Well, ask me, is it fairly light, somewhat hard, or hard? Okay? Now, if it's very light Or if it's very, very light, guess what? Tell me. Not working hard enough, right? So again, remember what I told you, like, this, if this is my exercise, I'm not gonna get very far. I'm gonna be good at tickling and scratching, if it's very light or very, very light, it's too easy. If it's very hard or very, very hard, that's too much, okay? So you want to be in the fairly light, somewhat hard range. So if you think about it like this, as like a ramp or a flight, right? So in the beginning, we're fairly light, somewhat hard, maybe at the top, we're cruising at hard or somewhat hard, and then, you also don't want to go from fairly light, and you also don't want to go like that, but same thing, you want to nice and gradually, you start your workout, it should be in the fairly light range, work up to somewhat hard, the most of the workout should be in the somewhat hard range, and at the peak, for a couple of minutes at the end, that should be hard, okay? And guess what? Over time, what happens is, your fairly light happens at higher levels, okay? And your somewhat hard doesn't come on till a new level, and then we move the goalpost. You know what I mean? That's how we do it. So I say to people, each time you come back and tell us that you felt well after the last session, we're going to give you a little more time, we're going to give you a little more intensity. Same with you. So I'm saying if you have access to a pulmonary rehab program and it's paid for, or you can afford to pay for it, that's my number one choice, okay? If you have the ability to come to New York City, work out with us for a month, that's my even better choice. But if you don't have access to anything, that doesn't mean, well, I can't get pulmonary rehab, so I'm just going to watch TV and eat popcorn instead, So you have to do something, and you can get fit with just a walking program and arm size and some weights. Okay, you can do it. Okay, it's not as easy, and it's not, and you still, of course, for all the stuff, should clear it with your doctor and say, am I safe to work out on my own? Learn about the oxygen. Okay, these are complex topics, and right now we're doing a doctoral level course in one day, in a couple of hours. And I mean, usually if I teach this to students or doctors, I'm teaching it over a 6-month period. So you have to go back on these things, and you're not going to get it all today, but ask me the question, I'll communicate with you. I also am close to finishing my book, which is going to be a reference on this, but the idea is that understand these things. So if I have nothing, if I have no rehab access whatsoever, I'm going to say to my doctor, do you think I'm healthy enough to start a walking program? I don't know. Do you think I need a stress test? Yeah, let's do a stress test first. Guess what? Your heart comes back good. All right, I'm going to start on a walking program. How much should I start at? Don't start at 20 blocks if you haven't walked in 20 years. Okay, start at 2 blocks. Okay, and here's another thing. I don't know where you live, but don't walk up 10 blocks, and then you can't get back. Okay, so walk out a block, and then come back a block. If that works, walk out a block and a half. You know what I mean? It's like swimming. Don't go out to that far buoy until you know you can get back from the shallow buoy. But then say to yourself, I need to work out in a fairly light, somewhat hard, and hard range. So if it means I'm going to start out, let me start out. Focus on your breathing, the breathing techniques, right? So the breathing techniques are breathing in through your nose, out through your mouth. There are people that will say that you don't have to breathe in through your nose. You don't. I prefer you to breathe in through your nose, but you get some benefit and a lot of benefit from breathing in through your mouth, okay? And then I'm gonna get a little quicker. Okay, I'm gonna get a little quicker. This is somewhat hard. Maybe at the end I'm gonna, really walk fast, or I'm gonna pump my arms, or I'm gonna go to a space where there's a hill. Okay? Understand these things, but understand what they mean. Don't just make arbitrary decisions because, well, I don't know, it seemed like a good idea. There's science behind all of this, and the science is supply and demand. And that means oxygen use, and that means activity. How your body uses oxygen is based on 3 main things. How good are your lungs at moving air in and out? How good is your heart at pumping blood? How good are your muscles at using oxygen? All 3 get better with activity. All 3 get worse with inactivity. So if you have a car and you take perfect care of your car, that's awesome. But if your filter is dirty and you don't use the right kind of gas and you don't have enough air in your tires, then you're going to get less miles per gallon, right? But if you change one of those things, it gets a little better. If you change 2 of those things, if you change them all, those effects multiply. And it's the same type of thing with all the things that I'm talking about today. So the idea is that start these things out, but use it based on science. Supply and demand. Just ask yourself, supply and demand. So if I sit here, this is more demand than doing nothing, but it's not very much. This is more. This is more. This is more. This is more. So as you do more, and it doesn't matter if it's a formal exercise or if it's cleaning out the garage or carrying groceries, the more physical work you need, the more demand. And that means you have to have more supply. And that supply can come naturally by improving the strength of your heart, by improving the mechanics of your lungs, by improving the muscles' efficiency at using oxygen. Or if you can't get it that way, that's where the supplemental oxygen comes in that allows us to increase the supply. And so that way we can meet that demand. And then it's circular, so it comes back around again, so that the body doesn't know you're wearing oxygen. Okay, that's another secret. So people have this myth and this idea. They say, well, I don't want to use oxygen because I don't want to become addicted to it. Let me let you know a secret. We're all addicted to oxygen. Okay? You don't get it for 6 minutes and you're not going to remember me the next time you see me. Okay? So that's one thing. Okay, but by using supplemental oxygen, it doesn't mean you're going to need it more. It doesn't mean that you're going to need more oxygen. It doesn't mean you're going to need it at times where you didn't need it before, and it doesn't mean you're never going to get off it. Okay? Some of these things are true sometimes. I'm not saying it's never. I'm not painting you a unicorn and cupcake story here. Okay? But let's talk with facts. Let's not talk with BS, and let's not talk with assumptions and things that it seems like that, but maybe it's not the truth. So if I were stuck in my own workout and there's a point that I want to break through, I'll give myself 4 liters of oxygen, and guess what? I just broke through that point, and my heart gets better, and my muscles get better. Same thing for you. So paradoxically, okay, and it's anti-intuitive, but paradoxically what happens is you're giving yourself more oxygen so you can do more, and by doing more, that makes your body better at using oxygen, so you actually need less oxygen.
I love what you're saying, but we're starting to have to wind down in a few minutes, and I want to make sure you cover diet.
Fine, let's talk quick. What is the time? How much time do I have?
As much as you really need, as much people willing to listen.
Okay, so we're not winding down. All right, let's put it this way. I will talk, if you want, how many people, give me an idea, in 30-minute increments. You want a half hour more, an hour more, an hour and a half more? Okay, so when we get to 30, I'm gonna cover the overview in 30, and then we'll go deeper if you want more after that. Okay, so let's move on. So exercise, we talked about frequency, intensity, time. How long should you be exercising? Everything is relative. Everything depends upon where you are right now. So if you're doing no exercise right now, don't go out and do an hour of exercise, of new exercises, because then what's going to happen is you're going to develop these musculoskeletal things. You're going to say, and I say to people all the time, listen, people come in sometimes the first day, we give them 6 minutes of arms, 6 minutes of bike, 10 minutes on the treadmill. Oh, I can do much more than this. I say, listen, take it easy. It's a long-term process. Okay, it's not going to happen overnight. But the last thing I want, you haven't exercised in 20 years. The last thing I want is for you to call me tomorrow and say, hey, I couldn't get out of bed after that workout, or you inflamed my elbow, or my bursitis, or arthritis, or all these different things. So take it easy. Think long-term. If you add 1 minute to if you can walk on the treadmill for 5 minutes today, you can walk on the treadmill for 6 minutes. Okay? So if you were to even add, just as one example, if you start with 2 minutes today and you add a minute a day, at the end of the month, you will be doing 33 minutes of exercise. Okay? So don't think you have to do it all in the first workout. Do it over the course of time. Okay? And we also want to make sure that we're preventing injuries. Okay? So that's frequency, intensity, time, and type of exercise. So there's a few different types of exercise. Most important is aerobic exercise, right? Because aerobic exercise is what's going to help your body get better at using oxygen by improving lung mechanics. I'm going to keep saying it because I believe it and I know it to be true. By improving the strength of the heart, by improving the efficiency of the muscles. Okay, that's things like walking, jogging, bicycle, either outdoor bicycle or exercise bike, UBE, upper body ergometer, new step, elliptical machine, swimming, any of that stuff, armor size. Okay, the key to aerobics is it's got to be at the right intensity and it's got to be sustained. So, and all of this has to do with science. It's all different metabolism. So, if we do a 100-yard dash, well, let's even start with that. If I put my hand on a hot stove, no metabolism occurs there. I have stuff stored. It's called stored phosphagens that are in my muscles. So that if I have to put something away, boom, it comes on fast. It's gone fast, right? Then there's the 100-yard dash. So the 100-yard dash is comes on fast, it's powerful, goes away fast. Okay? Can't sustain it. aerobic exercise is at a little bit of a lower level, so 50 to 85% or something, 90% of the maximum heart rate that we talked about before. But remember, I talked about the theoretical, the actual, and the actual, right? But the thing is that it's got to be sustained. So I would say if you're not doing anything right now, focus on the breathing exercises. The breathing exercises are pursed lip breathing. And don't get the idea that because you have restricted lung disease that pursed lip breathing is not good for you. Pursed lip breathing is an effective way for everybody to breathe. What it does, it pushes air back, it helps keep the airways open, it helps keep the alveoli, which are the air sacs, where gas exchange occurs, open longer, it helps oxygen circulate better. Pace your breathing, okay? So try to breathe. So there's a lot of argument also about what's the best breathing pattern for obstructive disease, what's the best breathing pattern for restrictive disease. It's not 100% one or the other, and they're not necessarily opposite. So obstructive disease are things like asthma, COPD, emphysema, chronic bronchitis, where people have difficulty blowing air out. Restrictive diseases include the interstitial disease, pulmonary fibrosis, where you have trouble breathing air in, right? But if you have trouble breathing air in, you have trouble blowing air out. If you have trouble blowing air out, you don't start saying like, wow, I'm really having trouble, blowing air out. But blowing air in, that's working out great. Doesn't work that way, okay? So I would say this. What I try to start off teaching people is we have to start with an ink stroke somewhere. And I'm not going to say for you it's going to be 5 and 7, for you it's going to be 12 and 3. No, the basic I start with, in for a count of 2, breathing in, out for a count of 4, blowing out, 2, 3, 4. So, okay, but if you really want to find out what's best for you, okay, and this is a chart that I invented for my book, is write down a list. Write a list of, on one side you put 1 to 10. On the other side you put 1 to 10. Inhalation, exhalation, and try them all out. That's how you know, okay? How long is that going to take? 15 minutes? And then we know for sure, as opposed to me saying, I know what's best for every single person in this room, what's the best way. In for 2, out for 4, it works for the majority of people. Breathing in for half as long as exhalation works for a lot of people. With pulmonary fibrosis, it's a little more difficult because it's hard to, keep that exhalation going for a long time because the lungs want to snap back. But rather than me say to you, here's the formula, I would say, take a piece of paper, inhalation, exhalation, 1 to 10, 1 to 10. And what I mean by that is breathe in for a count of 1, out for a count of 1, right? We know that's not going to work because I already told you that we have to get past the trachea. So in 1, out 1. No. Really, you need to breathe in at least for 2, a count of 2, to get past the trachea. But I would say try in for 1, just for the sake of a fun activity. Maybe not that fun, but in for 1, out for 1. How is that? See how it feels. In for 1, out for 2. How does that feel? In for 1, out for 3. By the time you get to in for 1, out for 3 or 4, you're going to realize this in for 1 is not for me. Let me try in for 2. In for 2, out for 1. In for 2, out for 2. In for 2, out for 3. You get what I'm saying here? Then if you try in for 3, eventually you're going to come to something that feels the most natural for you. And the more natural it feels for you, as long as it's keeping your saturation up, then that's the one you should use. And understand, because I'm talking a lot about supply and demand, okay? It may change with exercise. So what's good for you when you're sitting and doing nothing may be totally different than when you get up and start walking. What you do when you walk around your house may be totally different than what you do when you're on the treadmill. Does that make sense? All right. So the exercises I talked about, the breathing exercises, aerobic exercise, okay, strength training, very good. Now, for people with pulmonary fibrosis in particular, one of the biggest problems is that the work of breathing becomes so hard that you become calorie-burning machines, to where your metabolism is so high just trying to breathe. And that's a problem, okay? And that's a problem with breathing. It's a problem with maintaining muscle. It's a problem with maintaining fat, and it's a nutritional issue as well. So that's where all these things tie in together. So imagine this. I've heard people say, if you have pulmonary fibrosis or COPD, you're burning 10 times the calories of an average person. I don't believe that, okay? No one's burning 25,000 calories a day, but you're burning a lot more, okay? Now, here's the thing about weight, and I'm going to transition this into nutrition here, okay? Being the ideal weight is a big help when it comes to fitness and when it comes to breathing, okay? If you're 50 pounds overweight, and depending upon where that weight sits, if I have 50 pounds sitting here, imagine I have a bowling ball, a big bowling ball, hanging off each side of my rib, and every time I need to take a breath, I need to lift that bowling ball, okay? You ever see people whose neck muscles are very developed, their shoulder muscles are very developed, their chest muscles are very developed? Why is that? Because diaphragm's not working as effectively, and we're using what we call these accessory muscles. There's primary muscles of breathing, which is mainly our diaphragm and our intercostal, and there's accessory, which is if we're in a pinch, these muscles can help to elevate the rib cage. But being overweight is a problem because it's making you do more work to raise the ribs every single time you take a breath. But there's a certain point, okay? There's a certain point in time, and I'm speaking only in theory, don't get the idea that I'm saying this is going to happen to you definitely. But there comes a point when IPF can progress to where you're working so hard to breathe, meaning that you're taking in less air with each breath, and therefore have to breathe 20, 30, 40 breaths per minute, that you're just burning calories all day, every day. And if you're overweight, that may seem like a good thing because initially you're going to use fat for fuel. But if you don't have that extra fat, and you don't have, and you see, this is where all these things kind of tornado together. It's like we have Dorothy and Toto, then we see the house and the Wicked Witch. They're all in here, and it gets all confusing. That's why I'm trying to make it simple for you. So it's like, in addition to burning so many calories, another condition of supply and demand is that you can no longer take in as many calories, right? And food may not be as enjoyable because your smell and your sense of taste have changed. Or you can't take a big meal because when you take a big meal and sitting here, you have increased resistance to your diaphragm contracting downward, and then you can't take a deep enough breath. So it all, you need a strategy for each one of these things. And the key point is, if you need to lose a little weight, then I would say don't make that your top priority. I would say if you're 10, 15 pounds overweight, I would say rather than focus on losing that weight, I would focus on eating healthy and using your body to get in peak physical condition, workouts, okay, getting into peak shape. Now, if you're at a normal weight, okay, or if you're underweight, then you need to make a real effort to hold on to that weight. Because again, if your lung disease progresses, you're going to be burning calories. That's going to all, impact. And, again, if you have a lot of if you have a lot of fat, then that may seem like a good thing. But if you don't have a lot of fat, if you're used to being normal weight or you're even underweight, then the problem becomes, then you have to burn muscle, okay? And burning muscle is one of the worst things that you could possibly do. So let's talk a little bit about what we can do about that. I'm going to make one more comment on exercise, which is that the strength training is going to help you increase your muscle mass. And, Dr. Wong, I think we mentioned it last night, but if not, we'll talk about it. I'm starting to play with the idea of supplementing creatine for people, to increase muscle mass. But the strength training is going to increase your muscle mass. It's going to make you more efficient. But then we have to talk about nutrition. So here's the thing. Any quick questions on exercise? All right, so we've already covered medical and exercise. I'm gonna get you 30-minute people through the rest of it in the time allotted. But let's talk about nutrition. So again, Goldilocks. We don't want you too heavy. We don't want you too light. We want you just right. Okay. Here's the thing. So when most people talk about nutrition, they're gonna, there's three main nutrients. So there's carbohydrates, proteins, and fats. Right. Fats have been demonized forever. Okay. So a lot of times for healthy eating and heart healthy eating, they'll say, well, you want to take these complex carbohydrates and lean proteins, okay? But here's the thing. When you metabolize carbohydrates, so there's two factors here. There's the chemical aspect of it, and then there's the metabolism aspect of it. So the chemical aspect of it is that when you ingest carbohydrates, okay, so carbohydrates, particularly, sugars, bread, pasta, donuts, cake, cookies, all the good stuff, okay? The byproduct of carbohydrate metabolism is carbon dioxide, right? Carbon dioxide, when it goes to the blood, sends a signal to your brain, breathe, 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 because we have to blow off this carbon dioxide and we have to bring in oxygen, okay? So a lot of people, when they have these high-carb meals, okay, people think they're doing a good thing, they're eating pasta, they're eating this and that, in order to keep the weight on. The problem is that if it's also spilling a ton of carbohydrates into your bloodstream, it could potentially make you more short of breath. The other thing to keep in mind is that when we talk about protein and fat and carbohydrate, protein and carbohydrate each have 4 calories per gram. Fat has 9 calories per gram. So if you're trying to gain weight, okay, and for a lot of people that weight gain is crucial. It's going to be crucial to you, being able to breathe better. It's going to be crucial to you being able to stay fit. Load up on the fat. And I'm not saying the bacon and the ham. I'm saying there's healthy fats that will actually protect your heart, that will actually clean out the arteries and make your heart healthy. Things like olive oil, things like fish oil. All these things are cardioprotective while at the same time giving you more calories. And I also think that these things also reduce inflammation. So if we think about it from an overall decreased inflammation perspective, that's a benefit also. So if you are having difficulty maintaining the weight, I would cut the carbs as best I can, so no bread, or less of it. The bread, the pastas, the cookies, the cakes, the cereals, things like that. Don't believe the hype, okay? These people put a lot of money into making you think they're healthy for you, but you should focus on the lean proteins, okay? If you're going to get your carbs, get them in the form of fresh vegetables and steam them, or, make them in the healthy oils, okay? But increase your oil intake, increase your, your intake of protein, because protein is what builds muscle, and then use the olive oil, use these healthy oils. You can put them in anything, and they're not going to make you more short of breath, and they're not going to make you, they're not going to have this mechanical impact of preventing your diaphragm from contracting downward. But what they are going to do is they're going to increase your meal by 9 calories per gram. So if you're going to have, a milkshake, this may sound crazy, but you can put, a tablespoon or 2 of olive oil into that milkshake or into whatever it is that you're eating, and it's not going to change the taste at all, but it's going to increase your calorie intake. Again, supply and demand. It's increasing the supply, because the demand is the exercise, the activity, and the work of breathing. That's nutrition in a nutshell, okay? Now here's another thing. I just wrote a nutrition chapter. It took me 9 months. It was the bane of my existence for 9 months, because it was hard to find the right information, and every time I thought I was almost done, I found something new. I have a Facebook group. It's available on the Facebook group in our file section, okay? And I will build it. If you want, you can make that information available to people. But the chapter's there for free. The book is going to be available online for free. It's almost done. I've been working on it for almost a decade. It's going to be done by the end of the year. Okay, it's going to be on our website, so check back. But the nutrition stuff is so complex, but very simply, healthy, lean protein. Not the bacon, not the sausage. Yes.
You know how much you're charging for the book?
It's free. It's going to be free. If you want a hard copy, you'll pay 10 or 15 bucks for it. But you can read it online for free. Okay. Thank you for indicating my lack of money making skills. Okay. So that's nutrition in a nutshell. Okay. It sounds funny. Speaking of nutshell, nuts super healthy. Okay. And the other thing is that because it's harder for you to breathe, you're not going to take in 3 big meals a day. Don't try it. Okay. Think of them as feeding. Okay. Think of them as grazing 6 times per day. Every other hour, you should be putting something in your mouth to feed the system. Nutrition questions. I know that sounds short. It's a complex topic, but that's it in a nutshell. Read the chapter that's online, and I'll even send it to Bill, so if you don't want to join my group, it's okay. You can get it through Bill. Questions on nutrition? Yes, sir.
Can I ask a question off the subject?
Okay.
My family, as far as I know, there's no lung disease that's been present in any of my parents, grandparents, aunts, uncles, anybody. I was diagnosed with pulmonary fibrosis. Several years later, my older brother was diagnosed. Several years later, my younger sister was diagnosed. Is there any research along those lines
There's a lot of research going on. I mean, I can't comment on your family specifically, but IPF, idiopathic, means we don't know why it is. Okay, I mean, I'm sure there are definitely, there's pulmonary fibrosis. You can have pulmonary fibrosis and it's not idiopathic pulmonary fibrosis. People can develop pulmonary fibrosis as a relation to where they live, to their job, to the type of exposure they've had to different things. And then there's people who, no matter what happens, the cause is unknown. That's IPF. Question?
Dr. Christine Garcia at UT Southwestern is doing a study currently on familial IPF. Dr. Christine Garcia.
In my experience, I've never met 2 family members who've had IPF. It's just not my experience. I'm not saying it's not out there. Obviously, it is out there. But I've never had 2 patients that were family members that have IPF. Nutrition question.
One family in Denton, Texas, and had 17
So with that, I would say there's either a huge genetic component that we don't understand yet, or I would look at that community and say what's around there, or where did that family grow up, or what were they exposed to. Nutrition questions, only for the next couple of minutes if there are. Nutrition. Yes?
Before you start talking nutrition, something else, nutrition on meat or something.
So I'm talking about it from a carbohydrate perspective, okay, but there's a lot of people who have gluten allergies, okay, so they eliminate wheat and they feel a lot better. This goes to the concept of inflammation. I think inflammation is a huge, I can say another political joke, huge. It's a huge thing when it comes to disease, okay? And I think, if you have inflammation in your gut, if you have colitis, if you have inflammation, why is it that the same people wind up with pulmonary fibrosis and irritable bowel syndrome and hypertension and rheumatoid arthritis or scleroderma? There's inflammation and it's so damaging to our system, okay? So I would say this, for a lot of people, they have food allergies, they don't even know it, or this food will cause GERD, reflux, so I think it's all worth exploring, okay? You can't do everything. I'm telling you a ton of stuff now that pick and choose, look at your priorities, you know what I mean? So if you know that every time you eat wheat, you start to, you feel more short of breath, or you feel less energy, or something like that, then it's worth looking at. It's worth looking into, do you have a wheat allergy, a gluten allergy, because all these things, if these things cause inflammation, again, I don't believe inflammation exists in any one system by itself. I think if you have inflammation in your coronary arteries, you probably have inflammation in your peripheral arteries. I think if you have inflammation in your gut, I can't see how that doesn't in some way affect your respiration. If by no other reason, then your body's going to try to deal with this inflammation, and the way to deal with it is by bringing oxygen and healthy nutrients to the body. So I think that, again, that's that's where the gastroenterologist comes in. That's where, you can do testing to see, do you have allergies? Do you have, and then you can talk about the idea of elimination diets where you take stuff away and then, you add it back little by little, and then you can isolate, hey, every time I eat tomatoes, I wind up waking up in the middle of the night with this. So these things are very, very important. Sure.
You don't have to answer it.
No, I'm not single.
In your book, will you talk anything about food, diet, and cough? How that blends together?
No, but we can talk about it for a little bit. I think a lot of times there are people who have cough, okay, that is associated with eating, okay, or drinking, or things like that. So you eat, and then, you spend the next 15 minutes coughing. With something like that, I think you have to, again, the gastroenterologist or the pulmonologist to look into what is the relationship. Is there something going on, between your esophagus and your trachea, where maybe you're either swallowing air or you're swallowing liquid and it's going into the trachea and into the airways a little bit? I think that's the connection there. And, there's ways to test that. There's ways to test that. If it's something where you say, if it's mucus, that's one thing. If it's stomach contents, that's a different thing. So, but it's something that's worth looking at. It's way beyond the scope of what time we have left, but that's absolutely something that's worth looking into. Nutrition questions. All right, stress management, relaxation. And I'm going to give you 15 more minutes and cover everything, and then I'll let some people out. The rest I'll have hostage if you want to stay. So stress management, relaxation. It's very anxiety provoking to have a disease where you can't breathe. It's very anxiety provoking to have a chronic illness. It's anxiety provoking to the patient. It's anxiety provoking to the family. It's anxiety provoking to everyone in your community. Okay? It is the impact of stress and anxiety is, as we talked about before, it all goes back to the autonomic nervous system, which is that stress, anxiety, depression, all these things spill adrenaline into your system, the fight or flight response, okay? And the more anxious you get, the more short of breath you get. The more short of breath you get, the more anxious you get. The less you do, the more isolated you become, the more depressed you are. The more depressed you are, the less you feel like doing. These are all cycles. You see what I'm saying here? All these things are cyclical. A lot of them are behavioral. A lot of them are chemical. A lot of them are physiological. They're all physiological. But, and I think what we have to do is, one thing that I recommend to everybody, get a notebook and write stuff down on a daily basis. Write down how much water did I drink today? What did I eat today? How much exercise did I do? How much oxygen did I use? How did I feel today? Did I take? Because only by kind of tracking these things can we, you see how complex what we talked about, and how many different topics we touched on, and only by kind of examining each one and saying, what's similar on the days that I feel really good? What's similar, and you can say, hey, you know what, on all the days that I don't have a slushie, from some, whatever, on all the days that I don't have a bacon double cheeseburger from Art, I won't mention any, I don't want to get sued, but every time I have this thing, I feel more acid reflux and I'm more short of breath and I have trouble sleeping, and the next day I feel like crap. Okay? So you say, well, guess what? Maybe I should put this down and not eat it. But only by seeing the similarities and the differences and seeing what stands out about the days that make you feel good and the days that make you. So what I would do is I would get a notebook, and I'm going to do this when I go back, and I'm going to do it for myself and, my diet, my exercise. But each day, write down certain things. Write down, what did I eat today? How much exercise did I do? Did I do my breathing treatment? Did I use my acapella valve? Did I do any meditation? And you're going to find that on the days that you start your day with either exercise or 15 or 10 minutes of meditation, the rest of your day is going to be a lot better. Not every single day. Okay, if I meditate for 10 minutes and I go out and my taxi crashes into a chicken bus, I'm not going to have a great day, but it would be better than if I didn't do the meditation. Okay? So I'm going to bet that if you start doing these things and you find out it's like, hey, the more money I put in the bank, the greater my balance is. Same type of thing with your health. But I think it's really important when you're not sure what's going on, and it's really easy to get confused, and a lot of these things spill over into each other. So like I said, the heart, cardiovascular system, the lungs, the GI system, sometimes we don't know what is making us short of breath. Sometimes we don't know what's taking our energy. Sometimes we don't know what's causing this GI upset. Okay? But start, if nothing else, if you buy the notebook today or tomorrow, and you start taking these notes, it's going to at least remind you every day, hey, I could exercise, I could do this stress management, I could do these different things. There's a lot of great apps online now for meditation, okay? There's one in particular, I can't think of the name of it offhand, but it's a particular app, and it'll lead you right through. And the beauty of this is that so many of the meditation things are all breath-based. They're all breathing-based, they're all relaxation-based. And more so than just the breathing and the impact on the airways, as we talk about the autonomic nervous system, what they wind up doing is they wind up quieting the sympathetic nervous system, okay? They wind up quieting fight or flight. They dilate the arteries, they dilate the blood vessels, okay? And they increase the parasympathetic. And the parasympathetic is rest, digest, and heal. So stress management, relaxation training. Now there's some people who it's more than just that. Okay? There's going to be some people who have physiologic, chemical imbalances that are going to make them depressed or make them anxious. And in that case, by all means, consult with a psychologist or psychiatrist or your doctor. There's going to be times when meditation and all this stuff in front of us is not going to be enough. And by all means, treat it. Okay? There's a lot of people saying, I don't want to take medicine. I don't want to take medicine either, but I'd rather take medicine than be in distress. Okay? As long as the medicine is not going to ultimately put me in more distress. That's the fast stress management relaxation training. Okay? But there's one, and again, I have webinars on all these things on www.pulmonarywellness.com. It's not an ad, they're all free. Okay? But each topic, and I have great experts talking about these different things. You want a great stress management one? Go to the one, Richard Brown, The Healing Power of the Breath, and buy the book and get the CD that comes with it, and your life will get better. Question?
What was your website? What was that?
Pulmonarywellness.com. It's on my cards, okay? But Bill also will let you know if you need it. But pulmonarywellness.com, very simple. Last thing, prevention of infection. Okay, a lot of people try to shake my hand on the one hand. Many of the women try to kiss me. No, I'm joking. The thing is that, if I shake everybody's hand as they're walking in, if one person comes in, they have a cold, and every person whose hand I shake after that is important, okay? Is at risk for whatever that person had. Now, I told you that a cold for you is not a cold for me, okay? It could be more severe, it could be more debilitating. You have to think about what you're coming in contact with on a daily basis and how things get into our body. And I just wrote this chapter. It's made me complete germaphobe in a way that I've never been before, but I think I'm not getting sick though. But here's the number one way. So bacteria and viruses are the number one cause of most people getting sick. They'll come in through our eyes, our nose, our mouth, basically our mucous membranes. Okay? But how does that happen? It happens because I shake hands with someone who has pneumonia, and then I touch my face, and then I breathe it in, and all it takes is a little bit to get in your body. Okay? So there's direct contact, and the direct contact is I just shook hands with Typhoid Mary, or some of it is airborne, so you have a pneumonia and you're coughing in my face. But then some of it's indirect, right? So I'll use the New York City subway as an example. How many people hold on to that bar on any given day? It's disgusting. It's like a petri dish, right? So the number one way you're going to help yourself is by washing your hands frequently. Okay? You don't always have access to soap and water. Carry some antibacterial gel in your bag with you. And when you touch something, so again, I'm in the subway, I hold this. If I don't wash my hands, okay, I'm carrying this around with me until the next time I wash my hands. All it takes is a couple of times to wash your, touch your face or something like that. You just got sick. Okay, now, even if you do everything right, you still might get sick. But those are things you can do. Wash your hands regularly, okay? If you can't wash your hands, use the antibacterial gel. Carry a small, baggie of the antibacterial wipes, right? I don't know who sat here before. Or I get on a plane. A plane is one of the worst places you could possibly be because it's all recirculated air. You don't know who sat there before. I know when the last time they washed and cleaned the seats was. Never. But the thing is that before I sit down, I didn't do it this time, but I'm going to do it before my trip back. I'm going to wipe down that armrest. Okay? I'm going to go to the gym. I don't know who's on the treadmill, before me. And ideally, if you're sick, you should stay home. But I can't tell you how many times I walk into a class of yoga and the person says, "Oh my God, I have a terrible flu. I'm hoping this is going to clear my sinuses." But you don't know who's around you. But you can't control for everybody, but you can at least take precautions for yourself. I see a lot of people in masks here. Okay, that's great. The hospital has these dispensers all around. Use them. You go to the gym. We don't know who. You're supposed to wipe your machine down after you use it. Many people don't, but you know what? Even if you did, I say wipe it down before you use it, right? Because then you're not trusting the person before you. At our place, we wipe every single machine, every chair, in between every single use. So you hop off the treadmill, the first thing we're going to do is going to wipe it down. We tell you when you come in, use this. And if you're sick, stay home. If your family's sick, let them stay home. Okay? It sounds cruel and it's heartbreaking sometimes when you have a visit planned, but what good is it if your family comes to visit and you wind up with the flu or pneumonia or in the ICU? It doesn't do anybody any good. Flu shot every year. Okay, there's some new guidelines now about the double flu shot. Pneumonia vaccine, depending upon your doctor, some people will say once, some people will say every 5 years, some people will say 10. But protect yourself. Okay, don't have the idea that I got the flu shot. Next thing you know, I have the flu. The flu shot will protect you. Okay, but again, ask your doctor. I think most doctors will recommend the flu shot. Will recommend the pneumonia vaccine. That's prevention of infection. One other thing related to inflammation. I think that there's a huge connection between the gut health and the overall health, and I'm starting to become a huge believer in probiotics. Okay, I know Bill's a big believer. He drinks his gallon of kefir per day. The gallon leaves, okay. Well, it increases the gallon. But these things really make a difference. And I think, especially if you take a lot of medication, your stomach flora, the healthy bag, is way off. Okay? The one I like, I don't want to make, it's not an ad because I used it myself. I picked up a stomach bug in the Bahamas when I was sick. VSL3. VSL3.com. I think it's and the reason why I use it is because one of the top gastroenterologists at Mount Sinai told me that it's the only one where they've really done controlled, randomized, double-blind studies, and this one was proven. A lot of the supplements out there are unproven. Okay, the supplement industry is idiotically unrelated in a way that I don't understand it. But if you look at a lot of the supplements, you'll read at the bottom and say, these statements have not been proven or have not been approved by the FDA or the USDA. It's an unregulated industry. So a lot of times they'll do like an expose and they'll say, this doesn't even have in it what it says it has in it, or it has a lot of things in it that it doesn't say it has in it, or they're not in the numbers. But I think that protecting your gut is important. Question?
Is that V as in Victor?
Victor, Sally, Larry, 3.com. And again, there are other good ones. Okay, I think Align is a good one. One thing I'll say, I think, and intuitively, when I think about probiotics, I think the dry ones on the shelf in a bottle aren't, it's like Bill Maher says, I don't have any proof, I just know it's true. I don't think the dry ones work as well as ones that have to be refrigerated, or, I think it's hard to have live bacteria when it's just sitting on the shelf for 10 years. Yogurt, kefir, you can get it naturally, but not everybody likes the dairy. Question?
A quick question. We started early, going 18%, 5 different areas.
So
supposed to be 100 or am I?
Yeah, here's the 100%. So you said about 18%. So 18% is medical, having the right doctor, taking the right medicines, taking them properly. 18% is nutrition. 18% is exercise. 18% is stress management, relaxation training. 18% is prevention of infection. Okay, how much does that add up to? 90%. So the other 10%, it could be anything from 0% to 100%. That's everything else. Okay? Because you can eat right, exercise every day, practice your meditation, have the right doctor, prevention, wash your hands all day, every day. But if you step off the curb and break your leg, or if you get hit by a truck or something, there's a lot of wild cards out there. Okay? And that's why I leave it open, because it's not an exact science. It's not exactly 18%. These are the things that overwhelmingly over the last 20 years or so, or 25 years, I've found to be the most consistently effective in the most people. And I can stop there if there are no questions. What time is it? Anyone know? Sure. Sure. The rest is going to be questions. I've said almost everything I want to say. But I'll take questions for sure.
Would you like a copy of Dr. Greenspan's book? Okay. Would you like to get access to all his videos? Yes. Okay. Would you like to be abreast of all the news that's happening in the PF world and community? Yes. Okay. Then go to and register on our website at pfwarriorsofnorthtexas.com. pfwarriorsofnorthtexas.com. If you register on the website, you will get all of those things. We do mailings on them, and it gives you the opportunity to participate in this group, in this community. So pfwarriors.com, pfwarriorsofnorthtexas.com. And secondly, don't forget that Paula has the parking passes and tickets for both parking across the street. You won't get charged for being in the meeting. And I want to thank you for coming today. And I want to really thank Dr. Greenspan. And with that, if you have to leave, please do. And Paula, you have something?
Yeah, if for some reason you can't get out of the parking garages, if these tickets were given you don't work, just push the button and tell security you were here for a support group meeting. They'll open the gate.
If that doesn't work, put your foot on the gas at the park.
Please stay.
You know what? If you give me just 5 more minutes, I just want to stick around for one thing. I want to just talk about something quick and funny, but not funny. It's top 10 reasons why people don't get referred for rehab. Okay, so one of them is they're too old. Somebody asked before, is it too old? Okay, so this lady right here is. Oh, why is this not working right? We have a slow connection. Okay, how old is she? 93, yes, she is 93. She was 90 when we made this. That was 3 years ago. Okay? So look at we're going to see what speed she's walking at. You're never too old. Okay? If you're alive and kicking and breathing, it's worth a shot. It may work, it may not work. It can only make things better. Okay, so where is she? 8% incline, 2.9 miles per hour at 90%, at 90 years old, okay? They're too young. Okay, this is our friend from before. He just turned 90. He's got a facial disturbance, but...
How much weight is it?
60 pounds.
Looks like
45 pounds on there. But the beauty of this exercise, it helps everything. This is an exercise that's going to get you out of the chair. That's the exercise that's going to get you up and down the stairs. You can tell he's very shy. They're too sick. Okay, so this is a very classic photograph of the emphysema patient and the chronic bronchitic patient. But again, you know, you may be too sick for the treadmill, but there's always something you can do. And it's really a question of evaluating the individual. If you're bedbound, there's still exercise you can do. You know, it's like a great Martin Luther King quote: if you can't run, then if you can't fly, then run. I'm going to mess it up, but the bottom line is like, if you can't run, then walk. If you can't walk, then crawl. Everything is somewhere in the, I feel like George W. Bush, I'll be like, you can't fool me once, shit, you can't fool us again. That's what I'm trying to say. But the point is that there's always something that you can be done, that can be done. You're not going to convince me that there's nothing that can be done for you until you're dead. And then there's nothing we can do for you. The cancer's gone. This has to do with lung cancer, and a lot of times people will say, or this goes for any surgery, so it's like, you know, it's like, you've had the operation, you don't need exercise, or someone will send you home and say, just walk. Just walking is not enough. Just regular walking around in everyday life. I told you before that a walking program and a strength training program and an arm exercise program is enough, but just everyday activity, no, you're losing ground. They're getting chemo or RT. There's a lot of treatments that people will get, and they'll say, you shouldn't be exercising during these things. I find that it always works. It works to make it easier. Cigarette smoking, okay? I hope no one here smokes. A lot of programs will eliminate you if you still smoke and say, you know what, we can't take you right now, come back to us when you quit smoking. I don't have that philosophy because the very reason is, you know, we never see those patients again, okay? Some people quit, but I'd rather take you in. Yes, you smoke. Sometimes someone will come in, how you doing today? They say hello. A puff of smoke comes out of their mouth. But the thing is, I think you have a better chance of quitting smoking if you're starting to see some benefit of the exercise and the overall lifestyle thing. There are no pulmonary rehabs. Okay, and that's a tough one. How old is this guy? 97. There's not even any wheels on that bike. I'm across the gym. That's me when I'm older. What's that? All right. There are doctors that think they send every patient to rehab. I have doctors say, "Oh, I send all my patients to you." No, you don't. I don't see him. Or if you do, I don't see him. So there, you know, for the doctors in the room, it's important that if you make the referral, follow up on it to make sure that your patients actually get there. So, and you know, we don't take every insurance. We don't have the ability to see every patient, but I do know the programs that do take it. If I can't see you myself, I'll send you to one of the other programs that I think are good. So that is it for now. Before questions, thank you so much. Thank you, Bill. Dr. Wong is now going to come up and do a gangster rap for you.